Welcome, welcome, everybody. Just going to start in a minute once a few more of you join. So I want to welcome absolutely everyone to our third day of the seventh annual Patients Redefining the Future of Healthcare in Canada Summit. And I just realized that this logo on the first page actually says sixth annual. So my apologies for that silly mistake. Um, I hope if you were able to join our first and second days, they were full of just incredible content and and I'm very excited about the lineup of speakers and thought leaders and people doing incredible work that we have to share with you today who are generously offering their time and their expertise to all of us today. So today is our third and sort of final day in terms of content sharing. And our theme for the day is Echo Pandemics, Paving the Way to Value and Beyond Resiliency. Um, Tomorrow we do have another session. It is for patients, caregivers, and groups representing them, as well as citizen groups. So that's Friday. But so for those of you attending that, look forward to seeing you there. For today's agenda, after my brief introductions, sharing a few themes coming out of yesterday, and some housekeeping, we will start with the incredible lineup of content. And I will not do all of the bios, but we have Dr. Lafontaine joining us, Dr. Fernanda Poole, Eva Villalba, and a whole suite of incredible experts from various points of view on health data joining our health data panel. And then, of course, we will wrap up with breakout sessions with all of you, where you have an opportunity to digest some of what you've been learning and start to think through some of the implications of what you've been learning. So just a little bit of housekeeping. During plenary, please keep your lines muted, your videos off. During breakouts, so please, and also during Q&A, if you can feel free to ask your question, in person, so to speak. But please keep your videos and audio off unless you're asking a question during the moderated Q&A or it's during the breakout sessions at the end. We are recording the sessions in both English and French. And in order to access French interpretation, you just click on the world icon that's at the bottom of your screen. Then you would click mute original audio and then select French. In order to submit a question at any time, so if you're listening to a presentation and a question comes up, you can pop that into the chat at the bottom of the screen, send it out to everyone, press enter, and we'll see that, monitor it, and make sure the question is asked of the speaker at the appropriate time. If you have any technical difficulties today, don't hesitate to contact Axon Technical Support using the chat function. And please do help us spread the word, share what's on your mind with fellow attendees by using the chat, but also would really encourage you to share, insights, ideas that are inspiring you through your social media channels, and encourage you to please use one of these hashtags to let others know that you're part of this conversation and part of this event. And of course, it takes just so many incredible people and organizations to make an event like our summit possible. And so I really want to thank our two organizing partners, Save Your Skin Foundation and the Canadian Psoriasis Network, and all of the sponsors who make this possible, as well as our in-kind supporter, Axon, who provides our tech support for all of the days of the summit. And a big heartfelt thanks to our summit organizing committee members, Sharon, Louise, Antonella, Chantel, Kathy, Taylor, Marianne, Liz, Amy, Madge, and yours truly. And thank you to everyone who participates on our 3 working groups that continue some of the learnings and the efforts coming out of our annual summits throughout the year, and especially to the chair people of those working groups. So Eva for the Proms and Prems group, Chenille with the Health Data group, and Louise for Integrated Models of Care. Thank you so much to all of the volunteers who facilitate our breakout groups at the end of our first 3 days. So Stephanie, Lori, Megan, Martine, Cheryl Ann, Joanne, Antonella, Amy, Taylor, Eva, and Sharon. Thank you. And also thank you so much to our French interpreters who work really hard to make this more accessible for our Francophone friends and colleagues. Ciro, Amid, Joseph, merci beaucoup. And also our French translator who makes sure that we have materials available as much as possible in both of our official languages. So Rochelle Fecteau from Traduction Raison. Thank you. So as part of what we do each day is we reflect and sort of summarize some of the themes that have been coming through the event so far. In the interest of time, because we have so much good content today, I'm not going to, read out the themes from our first day, but they are here in the slides. And so if you think there's anything important, anything missing of important themes that came out of either Monday or Tuesday sessions, please do share them in the chat and we'll take note of those. And if they are themes that we're hearing from multiple places, we'll definitely add them in. So I will spend a bit of time just touching on the themes that came from yesterday's session of ecopandemics and the way forward in Indigenous health. So some overarching principles that we were hearing yesterday about working from the cultural foundations of distinct Indigenous communities when one is working in partnership with them, about how profoundly interconnected human and planetary trauma and health are, and just that very powerful quote from Sheila Watt-Cloutier of "Ice is our life force" being a really profound illustration of that. How we all fundamentally benefit from our relationships with the land and from learning from Indigenous leadership in their ways of knowing and being. How we are all leaders, whatever our titles may be. And that means that we have a responsibility for working from a position of strength and from principles. The theme of education continued through, and really the essential, our education such that we're able to promote empathy and trust. And how learning through language and culture touches our whole selves and not just our intellects, and therefore has a lasting effect through our lives. So I'll just pause here. These are some themes on content coming out of day one, if you want to take a look at them in case you think we missed anything because you were there. And then for day two, some of the sort of content-oriented themes we were hearing about the need for funding and for support of self-governing healing centers that use culture as treatment, that use land-based healing approaches, and overall the support for the creation of dependency liberating solutions, to use Sheila's language. The importance of funding for prevention and infrastructure, including housing, clean water, not just, rather than the emphasis on reactions to crises after the fact. The root causes of most socioeconomic health, mental health, criminal justice challenges experienced by First Nations, Inuit, and Métis brothers and sisters across Turtle Island being the root causes being trauma and intergenerational trauma. OCAP on ownership, control, access, and possession, and participatory research approaches as really important when looking at and collecting and learning data and information specific to the over 600 First Nations across Canada. And these are unique and discrete nations with their own cultures, languages, relationships with the land, etc. And so such that, needing to really have that understanding what's happening using approaches that are about self-determination, self-governance, and such that umbrella approaches like Indigenous or Aboriginal may not work in when you're working with a particular community. And also harm reduction as being an important tool in the toolbox. And we heard from Rod Jeffries about the innovation of a managed alcohol program in one community during as a response to what was happening in their isolation during the pandemic. So again, I'll just pause here on some of the process-oriented themes that came from day one, so you can take a look at them and see if you think we're missing anything. And then a couple of process themes coming from day two. Our role as people not Indigenous to Turtle Island is to support our Indigenous colleagues. The importance of building relationships with First Nations, Inuit, and Métis partners, and acknowledging that this takes time. And again, quoting from Sheila, change will occur at the speed of empathy and of trust. So just a reminder that we do send out an evaluation link after each day of the summit, so we can hear from you about what you loved, what we can be doing better. And we really value your feedback, and I do encourage you to please fill out the very short survey. And now I'm very pleased to pass the virtual mic to my friend, colleague, and co-organizer Sharon Clark to get us started today.
Thank you, Leah. I have the honor and the pleasure of introducing Dr. Lika Fontaine. He's currently the president of the Canadian Medical Association. He's an award-winning physician and the first Indigenous doctor listed in Medical Post 50 Most Powerful Doctors. He was born and raised in Treaty 4 territory, which is just south of us in southern Saskatchewan, and has a Métis, Ojibwe, and Pacific Islander ancestry. Dr. LaFontaine has served on numerous medical leadership positions for almost 2 decades. In particular with the Alberta Medical Association, the Canadian Medical Association, and the and the Royal College of Physicians and Surgeons of Canada. He is a member of the board of Healthcare Can. He is also a vice president and president, my tongue's slipping off of me. He has also served as vice president and president of the Indigenous Physicians Association of Canada. From 2013 to 2017, Dr. LaFontaine co-led the Indigenous Health Alliance Project, one of the most ambitious health transformation initiatives in Canadian history. Led politically by Indigenous leadership, representing more than 150 First Nations across 3 provinces, the Alliance successfully advocated for $68 million of federal funding for Indigenous health transformation in Saskatchewan, Manitoba, and Ontario. He was recognized for his work in the Alliance by the Public Policy Forum, where Prime Minister Justin Trudeau presented the award. In 2020, Dr. LaFontaine launched the Safe Space Networks project with friendship centers across British Columbia. Safe Space provides a safe and anonymous workflow to report and identify patterns of care. Patients and providers use the platform to share their own experiences and contribute to system change without the risk of retaliation for sharing their truths. Dr. LaFontaine continues to practice anesthesia in Grand Prairie, where he has lived with his family for the last 10 years. So with that, it's my honor to present Dr. Lika Fontaine. Thank you.
Thanks so much for that introduction. I'll have to shorten it, but absolute pleasure to join everyone today virtually. I think one of the best parts of being president of the Canadian Medical Association is the opportunity to interact with patients and with providers across the country, and actually talk about things that matter, particularly their experiences and whether or not healthcare is providing what it needs to provide as folks try and get to that point of having their care managed. So I went through a different things that I could present today, and I think probably the most useful part that I could share is just related to system change from my point of view, having been in system change for quite a long time. I think for many people, and I imagine for patients as well, how do you actually make systems change is a big challenge. We put a lot of time and effort into what we do, and we don't always see an enormous impact as a result of the enormous amount of effort that we actually put in. And so this is a dense topic that you could probably imagine it's tough to present in 30 minutes. So I'll kind of get in there. Just for those who are online, I am going to be asking a couple questions that we'll use chat. So if you don't have that chat window open, just have it open for a little bit later in the presentation. So just a really quick presenter disclosure. I don't really have any. As president of the Canadian Medical Association, I do receive a stipend as part of the work that I do with the CMA. Other than that, I have nothing to declare. So the way that I usually start out these presentations is just to talk about these systems that we all kind of live and work in. So society is kind of built within this soil that is a social fabric and kind of an economic system. So the social fabric are kind of the shared values that bring us together, the shared ideas and beliefs about us working together and connecting with each other. Economic systems are really about us defining how to exchange value. So although with economics, we mostly talk about prices and stocks and all these other things, economic systems are really how do we value the things that we do and how do we exchange that value in some sort of form. So within that system, there are certain things that grow. And so what are some things that grow within our society that are supposed to provide, fruits of our labors in order to promote positive things as far as growth and support, things like health, education, social support, and housing. So in recent years, the soil that this has all been kind of rooted in has really started to dry out, and as a result, a lot of the systems that we have started to wither, and in some cases actually feel like they're dying. So when we're talking about collapse in a system like healthcare, this is the result of the social fabric and our ways of exchanging and defining values starting to kind of fall apart, not be that rich, fertile soil that it used to be when health was kind of growing and thriving. And for many people, these systems actually feel like they're on fire. And I will say, as a provider and as someone who's supporting family members going through the health system right now.
Can you hear me?
Yeah, I can hear you. Yeah, so for those who are going through the system right now, it may feel like the system actually is on fire and just is not performing the functions that it's supposed to do right now. So I did a quick review of just the news stories that have been published over the past little bit. This is just the last 48 hours. You can see there's an enormous amount of patient stories and patients sharing their stories about this healthcare system that to many of them feels like it's on fire. People are wondering how they're going to navigate care. They often don't feel that they're able to access care. In certain places, it's clear that you cannot access care. If you are a pediatric patient in an overwhelmed hospital where there's no PICU beds or inpatient beds, you could come in with a significant condition that does require treatment. And it is a real reality right now that we may get to a point where things are so overwhelmed for kind of our younger demographics that there may just not be room within the hospital structure as it exists. And so obviously there's things that we try and do to mitigate it. In previous COVID waves, we talked about field hospitals and other things. We start pulling people into parts of the system that they weren't necessarily trained to do. You are seeing the beginnings of the same sort of calls for pediatric patients across the country. And so what I really take away from this is that the system's not really working the way that it should, and it's not providing what patients are asking it to provide. And as a result, we do have to discuss, how can we change and transform the system moving forward. Patient voices are more present than ever before in the discussions that we're having. All that notwithstanding, the status quo is still very slow to change. And so the question is why? So this is part of the interaction just with folks online. So I'm going to just ask you to go through an exercise real quick where I'm going to have you count some F's in a paragraph. All right. Some of you may have seen this before, so I'll just ask for you to participate again. I'm going to ask you within the chat how many F's you saw. Please don't type in your answer until I do ask the question, just so folks can have the chance to, reflect on what they did. So I'm just going to put up the paragraph here right now, and I'm going to give you 3 seconds just to read through right now. So here's the paragraph here, and I'm just going to give 3 seconds, 1, 2, and 3. And I'm just going to ask folks who went through this, if you saw 3 Fs, can you just type that into chat right now? Yeah, just type the number that you've seen in there just into chat. Okay, perfect. I'll just give a minute for folks to kind of type that in. All right, and I'm going to ask anyone who saw 4 Fs to type in the number 4. All right, here we go. This is always more fun in person because folks who typed in 3 start to get a little nervous. Anyone see more than 4 Fs? If you can type in the number that you saw. Now, folks who typed in 4 Fs are starting to get stressed out. So you can see from the chat, there was a large proportion that saw 3. There was some that saw 4, and then one person here just typed in that they saw 5. So these are how many Fs are actually in here. So there's finished files, which is 2. Years are the results of years of scientific study. That takes us to 5, combined with the experience of years. So there's actually 6. So I presented this across the country in many different environments. As the group of people gets larger, you eventually start to see this convergence towards these kind of distributions. So in large groups where I presented, about half of the folks who go through this exercise see 3 Fs. About a quarter of people who go through this exercise see 4 Fs, and about a quarter see 4 or more Fs. All right, so if this was a group of 300, 400 patients online, you'd probably see a migration towards these numbers here. So you have to wonder, if you present this over and over again and you continue to get the same sort of result, there must be some sort of reason behind it. And I'm going to suggest that we end up having similar experiences because we actually share similar mental models, ways that we interpret the data that is presented to us in our human experience going through the world. So within these mental models, when it comes to this specific exercise, there's some things that you can actually suss out if you sit down and take the time to talk to folks who go through the exercise. So the first is, people often report back, well, I was reading the paragraph for content. And when you're reading for content, you tend to move away from the task which you are given, which was counting the 3 Fs. Instead, you're trying to look for the meaning in the paragraph. And some of you may have been doing this. When you look for meaning, you often skim over small words because you don't have a lot of time. The content of the paragraph is held in the larger words. And so you may have looked to words like scientific and use those to count while ignoring the smaller words above because they tend to be filler. So the third reason that's commonly given when asking folks about why they responded to this exercise in this way is that people often read aloud. So when you're reading the word scientific in your head, it sounds different than the word of. And lots of us who read, I still do this, I kind of read in my head, and those sounds kind of trigger the feedback that we're looking at with the question. Now, there are certain groups that don't share this similar experience because they don't have the same sorts of mental models. And so this mental model actually doesn't work on folks who don't have English as their first language. I'd say that you can differentiate between 2 groups of people, those who are English speakers and those who are not, based on what language they think in. So if you think in English, then this will probably work on you. If you think in another language and then translate into English, this will probably not work on you. Also, for whatever reason, those who are not formally schooled past grade 4 tend not to have this work on them for whatever reason. There's something that happens in grade 4 that changes the way that people react to this. So I'm gonna have you go through one more exercise. There's gonna be 3 triangles, kind of left to right. And I'm just gonna have you read them real quick. I'll give you 3 seconds again, and I'm just gonna put those up now. So just read through triangle 1, read through triangle 2, and read through triangle 3. And I'm gonna ask you just to read them again. So if you did not see what was in the triangles, I just want you to type in no, just into the chat. So if you didn't see what was in the triangles, just type in no. I'll just give you a moment to do that. Okay, thanks for that. If you did see what was in the triangles, type in yes. So what's interesting about this as well is if you start to scale this across a large group of people, you actually end up getting near the same numbers that were before. Yeah, to Nadine, it was whether or not you saw the double words. And so it's also interesting that Gail said she was on alert now when it came to duplication, because the really interesting thing about mental models is exactly what you actually just said, Gail. If you're not consciously aware of them, they kick in. So what are mental models? Well, they're shared beliefs that come from a shared experience, influence, etc. And they often become a part of how we define ourselves. Mental models unconsciously and consciously signal to us how to act. Not only act from, a social norm sort of thing, but also how to act when we consume information. So bias tends to drive behavior in the absence of an intervention. If I was in the same room as all of you right now, I mean, I'd be looking around as an anesthesiologist, someone that puts folks to sleep for a living and kind of provides critical care support. I'd be looking to see whether or not you were difficult IV starts, right? Like I can't help myself from deciding whether or not people would be difficult airways if they ran into an airway problem. It's just part of the mental model that I've kind of formed over years of working my craft. The interesting thing about mental models is that they don't have to be true, logical, adaptive, or realistic. We often think that bias is this logical line towards the outcome that we want. But the truth is there's a lot of times that our mental models are maladaptive. So for those of you who weren't able to see what was inside the triangles, your mental model of how to read through things was maladaptive for the tasks that you were given. They weren't important tasks, but they were maladaptive for the tasks that you were given just now. Now, the take-home message for mental models that I really want to drive to everyone who's online right now is that if you change mental models, you will change behavior. They're always tied together. So bias drives behavior, and changing those underlying mental models changes belief and thus changes bias. Now, the question that I put out to participants today is, what is the mental model for change that we are all taught is most effective? And I'm going to put up a image right here that describes what I've always been told is change. I mean, we use this all the time in healthcare when we're looking to transform the way that people talk about something. So the first step is you organize a committee. The committee drafts a framework. You then take that framework out for public consultation. You then produce a draft report that brings together both that framework and public consultation. You then do another public consultation, after which you finalize the report, because now you've gotten enough feedback to have confidence that your report is saying what it should. You then publish the report, you do a media blitz, and then you start to promote recommendations. And these recommendations have now been reformed into being calls to action or charters or other things. And you put an enormous amount of effort into having folks either sign on to these recommendations, sign an MOU, make some sort of public declaration that things are going to change. But the question that I just leave with everyone is, how often does this actually work? And when I started working in the Indigenous Health Alliance, this was a question we came back to over and over again, because we actually had a data set of, hundreds of individuals across, more than 150 communities that were using this every day. So thousands of, little mini reports, stuff in the gray literature that would go forward to organizations that at the end of the day just would actually not change. And so I would suggest that in a lot of cases, this sort of approach is maladaptive to what's actually needed. Changing systems is a lot different than changing people. And when you're looking at the most important factor in high-value person-centered healthcare, it's actually the folks who provide the care, right? And this is always interesting when we talk about things like racialization, cultural safety, patient experience, whether or not patients feel supported in their healthcare journey. We always talk about that person who maybe is a barrier to achieving those things. But then there's also those folks who really, for whatever reason, seem to be able to work within a broken system to provide us the things that we need. And I'm actually going to suggest that changing systems is maybe a little less important nowadays than ensuring that those people across from you as you go through that patient experience change. And so there is a difference in approach between changing systems versus changing people. And that's really the meat of what I'm going to present today. So change is a human experience. And what this is this is the Kubler-Ross change curve. Some of you may have seen it before, but what it shows is the human experience of going through system change. So you start off with a step called status quo, which I'll explain in a little bit. You get more motivated to change when your status quo does not address what it needs to, which then leads to a crisis. So you can see that motivation in the graph actually starts to rise and gets at its highest level when you get into a crisis. As you move forward, people start to go through a stage called denial, and you start to get a downturn within the motivation of people to change. Once you get into the resistance part, which is lower down in the curve, it's actually a downward slope that gets a lot more sharp and kind of bottoms out. People are most resistant to change during the resistance phase. As you start to get out of that resistance phase, you move to exploration, and then you move towards commitment. And I'll define all of these steps just right now. So where system change tends to focus is in the areas of crisis, exploration, and commitment. And all of you have probably been through experiences where a crisis has occurred. You get a whole lot of attention for the things that you're advocating for. And people immediately start to talk about, the commitments that they'll make, about the system that they want to create. You talk lots about this idealized future state of the system and how that could fix things. But that tends to be where a lot of the conversation tends to focus. Where people change happens is actually a different part of this human experience of going through change. It happens within the status quo, within denial, and within resistance. And I'm going to go through and just define each one of the steps, as well as articulate a bit about what we did in the Alliance when it came to figure out how to work through each one of these steps. So with the status quo, you can define that as a collection of mental models within a given system at a given point in time. When you walk into a family doctor's office, or you walk into an emergency room, or you go see your nurse practitioner or the primary care provider, the expectations that you have for that care are essentially the mental models aggregated together. And so you can separate those out. Whether or not you feel safe within that environment identifies whether or not there's a mental model of safety and how safety is defined. Is safety defined from the point of view of providers and those within the system having zero tolerance for patients being upset? Is that centered around patients feeling like they're safe and listened to and trusted, et cetera? So it's really important within people change to define what your current status quo is. And I can't underline this enough. If you're able to define your status quo, that can then lead you into other parts of the model where you can start to articulate where those mental models are. And the most important part of the status quo and creating the change that you want to create is you have to figure out what your status quo is right now and why it's maladaptive. Like, why is the things that are believed in the system right now actually leading to the very crises that you're trying to avoid? Now, crises are the inevitable result of maladaptive status quos. So when you have hospitals overwhelmed with pediatric patients, when we had previous waves of respiratory illness and they overwhelmed the capacity of, the healthcare system to deal with those challenges in years past, in months past. There are certain mental models that were quickly articulated. There's mental models around, not having enough healthcare providers, mental models around the way that we share data, and we've really accepted like this delayed by 1 or 2 year aggregated blunt instrument of data collection. We've really accepted that we should group people into just a single category instead of articulating what they actually do. A nurse is a nurse versus an ICU nurse is different than an emerge nurse, who's different than an OR nurse, who's different than, even within those subsets, emergency, you have people who work in trauma and those who deal with, geriatric medicine. So, we've accepted these maladaptive status quos, which then continue to push us into these crises. So crises are actually a really, really important part of all of this because they fuel the momentum for change. And for those of you who've gone through and done advocacy in this area, you probably had experiences where a crisis occurs and then, there's suddenly a offer to meeting a bunch of people who didn't want to talk to you before, or to, sign on to some sort of a charter that people wouldn't have considered before. It's really important in this stage to differentiate between when people are simply trying to de-escalate the response to the crisis, so how upset people are, and actually resolving the crisis itself. When it comes to the denial phase, this is the intuitive pushback that people have when status quo mental models disalign with the more adaptive mental models that would actually take us out of these crises. And so in this stage, articulating those mental models like what they actually are is really, really important and very, very valuable in moving forward, that people type of change, because people change happens in status quo denial and resistance. Now, the most entrenched mental models tend to be linked to self-identity and sunk cost bias. So if as a physician, I have within my mental model that even when I create harm, I'm still inherently a good person, and that I can't hold the two disparate ideas of I could be creating harm in the way that I act, and I'm still a good person because I'm sacrificing so many things in my life to provide medical care. You'll never have the space to be able to rethink that mental model. And so when we talk about safe spaces to kind of discuss and unpack some of these mental models, what we're really doing is creating safe spaces for people to re-explore what they believe, and particularly how they self-identify. You know, sunk cost bias is when folks put a lot of time and effort into certain activities, and a shift in mental models would actually negate a lot of that work that happened. This is where the frustration that I think from both providers and patients occurs when, people do a bunch of stuff, put in a bunch of resources, and then it's clear that it's not working, but they still want to carry on with what they're doing, right? So that's sunk cost bias. Resistance, where everything kind of craters, is this conscious, organized pushback against changes. Now, that's very different than denial, which tends to be intuitive. This is deliberate. And the reason why resistance is so deliberate and so strong, and why opposition to change and motivation really craters here, is because it has to do with redistributing resources. And so a person will suppress the mental models that disalign with change that needs to occur, but they'll die on a hill when it comes to loss of resources. Because what does loss of resources translate into? It translates into lower income. That may translate into the inability to actually financially sustain, your clinic or kind of your method of practice. It may mean that, one of your colleagues gets fired, or your team gets dissolved, and you all get redistributed to places that you haven't worked before. It also means loss of influence, no longer having a seat around the table, et cetera, et cetera. Within this stage, it's really important to think about pragmatism. We often think we can force our way through people's resistance to loss of resources and opportunity, but it's actually more pragmatic just to negotiate that shift. Instead of saying, you're just going to come along and no matter what, we're going to move forward with this change. Instead, ask, well, what's your value proposition? How are you going to shift so we can all achieve, the different status quo that we're actually trying to achieve? So the latter stages of system change, exploration being one of the last ones, is really structural changes in systems that make a return to the status quo difficult or impossible. Now, these are most effective when they entrench new mental models that are actually functional, and they have to do with resource allocation, which is really working through your denial and resistance phases and making it part of the new way that the system tends to work. And finally, with commitment, this is where you have a change in mental models. You're actually resetting your status quo. And just to underline this point, all status quos become maladaptive over time. And so even this new status quo will eventually become maladaptive. So even though we achieve the change that we're looking for, eventually that change will become out of date because of the way that society evolves. And so you do to some degree always have to be on the lookout of whether or not your new status quo has become maladaptive, and that can happen fast or slow depending on things happening. So failed change is really a cycle. So when you're feeling like you're back at the same spot that you were in previous work, this isn't in your head. This is actually literally what is happening. And so what happens is we go through these different phases. We don't get through denial and resistance. So we actually get reset to status quo. Now, the very dangerous part of all of this is repeated failed change is actually a downward spiral. And so when we repeatedly go through cycles where things don't change, you end up having something called weathering occur within your system. And you get a deterioration of resiliency. You get an entrenchment of the status quo, which means people are even more willing to deny that change is happening, and they're more emboldened to resist any changes. And that actually just leads to an entrenchment of the status quo and actually worsening crisis. And we've seen this in real time with COVID waves. I remember in the first COVID wave, very motivated to make changes in the system, very hopeful that changes could happen. Every small little win felt like an enormous victory that really motivated us to deal with these problems. By the fifth cycle of the wave, where nothing changed, or very, very few things changed, we were so weathered that, you know, people would call for assistance, and we would still provide assistance, but like every small step felt like an enormous weight was on our shoulders. And I'm sure that this is a similar experience for those of you who've gone through patient care and are really frustrated that things just have not improved. So just to bring home some of these insights, you know, status quos will never change unless people and systems change. And so having both of those strategies is actually super important. The practical advice number one that I'll share is that people hold most tightly to maladaptive mental models when they are entrenched in self-identity. So once again, if the mental model is linked to how people establish their own self-worth, it's very, very difficult to have people unpack that mental model unless you create that safe space for them to kind of reform their identity, because that's actually what you're asking them to do. Also, with sunk cost bias, this often gets tied into self-identity. Behavior is always rooted in mental models. So this is a part of the human experience of going through change that you actually can't avoid. You have to work your way through this. The second piece of practical advice is it's very human to resist loss or perceived loss of opportunity. You know, we often look at folks who don't want to come along to change that's very clear to us that needs to occur as somehow maybe not having strong moral footing, or, you know, maybe just like not sometimes being good people. You know, I see this conversation kind of move into different parts of what we're dealing with right now in healthcare. Personal interests always supersede mitigating crises. Like, this is just human, right? If someone takes away your ability to take care of your family, you know, sustain kind of the life that you have, like you will fight and resist for that. And so negotiation is a really important part of all of this. This is not to say that we compromise on things, because I don't believe compromise leads to proper system change. You do have to make the changes that you need to. It's just maybe just keep in the back of your mind a little bit more empathy if you need to, and just recognize, like, this is a human experience. Like, it is normal for people to respond and resist change that affects their perceived or real loss of opportunity. So these are some areas where the CMA is working right now just to change the status quo. You could probably see in the media me talking about a lot of these different things. There's been a lot of work in unpacking, you know, the mental models that underlie some of these issues, and then trying to articulate, you know, what do we need to negotiate through. For example, with Pan-Canadian licensure, there was an insight that we've had recently that registration of providers is different than self-regulation, and separating strategies into those two parts as part of the human response to system change has actually helped to move the conversation along quite a bit. And we'll have insights that happen within each one of these areas, and your opinion and perspective and experience is really, really important in not only understanding those mental models, but also why providers may resist change, you know, and also why patients may resist change as well. So just a closing thought here before moving over to some questions. You know, system change often ignores people changing, and it's to our detriment, because changing people always changes systems. And so just encourage all of you in the important work that you're moving forward, just to keep that in mind. And really happy to take some questions now. Thank you.
Hi, thank you. That was excellent. Sure gave me some great ideas, and I've been writing furiously, and so that's very good. So we have some questions for you. Let me see, or actually a comment. I really like Pan-Canadian licenses. It is a way to load balance the system and probably provide better balance for practitioners. Can you say a bit more about this Pan-Canadian licenses?
Yeah, absolutely. And so, you know, one of the places that one of the places that this might actually come to fruition is just in the area of the maritime provinces. I know that discussions there are a little bit more advanced. We also know that a lot of the regulators that resisted in the past are starting to recognize that, that this might be more of a priority than they initially thought. With pan-Canadian licensure, it makes so much sense to providers and patients because we kind of live in that workflow every day, right? Like we see the struggles when people come and visit to provide care. I'm sure a lot of you have experienced care from locums over periods of time. Like you probably hear from us about the frustrations of having to register to work in a place for a week and having to spend, months of effort to get to that point. And also there's just the reality that the jurisdictional system just hasn't kept up with the changes in how people move. When we first started in healthcare, it was like one-to-one. You had your clinic in your community. That's the only place you ever went to for care. And then we evolved into having multiple different locations where you could go for care. And now everyone's hypermobile. You'll have a person providing care in Alberta, but living in Nova Scotia. I mean, that's one of the members of our department, right? And so those mental models haven't kept up with the way that society's evolved. So pan-Canadian licensure is a good example of how to kind of confront that in a different way.
Okay, thank
Yeah.
you. That might help with mobility too for doctors, right?
Absolutely.
Okay, so here's a question. If people fight to live, why are people so passive about the fire in our systems, our fire our systems are in, that you mentioned, the health, education, housing, and social systems?
Yeah, so I think part of the reason that we divide the social determinants of health from health and healthcare is because our systems were structured to not actually consolidate those things, right? Like if you look at how it practically works, so you have different departments, which means you have different budgets, which means you have different oversight, which then means you have different groups of providers. What have we realized over time is that everything's kind of in a continuum. I mean, I can see you for pain control, but if I send you back to a home where you struggle to keep your place warm, and that's one of the triggers for your chronic pain, it doesn't matter how much I change your medications, you won't be able to get a handle on, your pain control, right? If you're a person who needs to be on a variety of different medications to help your dementia, for example, if you go to a location where you don't have family support or social support to, make sure you're fed and, you drink and walk around and exercise at some degree, get social contact, and then also take your medications on time. It doesn't matter what I do inside the healthcare system, but our systems haven't really caught up to that. I think we are negotiating to new ways of providing care. One of the hopeful parts I see is what's going on in BC. People are shifting towards revaluing certain parts of care. And it's not going to be an easy process. People are very scared of change. And the truth is, the system is hyper-focused on cost containment. We're one of the few countries in the world that, like, family doctors are a referral point before you can go see a specialist. That doesn't actually exist in a lot of other places in the world, right? So that was introduced as, a way to manage costs within the system in the context of, other priorities. And so it's really about shifting what drives care. And I think when patients sit there and ask, well, why aren't you supporting the needs that I have? A lot of that has to do with just the shifting needs that people have now, and that our systems have not kept up with evolving to support those needs. And so what do we need from patients? We need you to continue to share your experiences, but we also need to start working together to articulate, what are the new mental models that kind of underlie things, right? Because we've said it lots of times over at the Canadian Medical Association, myself and my predecessor, Catherine Smart, we can't continue to put money into a system that just does not deliver the results that people are asking for. And why do we not deliver results? It's because we continue to cling to old ways of thinking and doing things.
Mm-hmm. Absolutely. Thank you. Another question. I'm interested to know what CMA's current position is on expansion of scope of practice for healthcare professionals that can help alleviate some of the burden on doctors, especially nurses and pharmacists.
Mm-hmm. So I actually think that's the wrong question. So I'll tell you two things that have shifted. So 10, 15 years ago, we would have never had this conversation. I would have said, doctors should be the quarterback for care, and that's the only place you'd go for care. No one really feels that way anymore to a great degree, right? But the issue that you get into is that people are not interchangeable when it comes to the ways that they're trained, because we're trained differently, right? And that's something that became very, very clear within COVID. There was a call in Ontario for, family doctors and medical trainees to come in and serve the role of ICU nurses. Like that was completely inappropriate. I mean, the training does not put us in a position where we're the equivalent of an ICU nurse. I mean, as an anesthesiologist, most of my job is real-time pharmacology. So I give you drugs and certain effects happen. Like, I'm not going to argue that I'm a pharmacist, right? I've gone around and done circulating for nurses in the OR just to help out. I'm not going to argue that I'm a circulating nurse, right? And I think what's happened within our current structure is primary care has become, how do you replace the lowest cost person or put the lowest cost person in the highest cost person's position, instead of asking, what are the tasks that we can do and do well?
Mhm.
So the most dangerous part of all of this is if we simply switch out who is the face that you see without transforming things into team-based care and moving towards a learning system where you actually know whether or not you're getting the care that you need, we actually don't solve any problems when we introduce a bunch more. So a pharmacist currently runs a primary care clinic in Lethbridge, and I don't know anything about that person's practice. But what I do know is we don't actually know anything about that person's practice from a healthcare system point of view. I've asked, how are things going, and all that people can provide is how many patients they see during the day. So once again, it's that volume-based lowest cost paradigm, that mental model that underlies the way that we structure care. So me personally, I care that you have your problem solved. That is the right question. So the question that I think patients would get more traction out of, instead of getting caught up in this mental model of scopes of practice, which I think has been outdated with the way that we've kind of evolved as healthcare teams, is instead to ask the question, who could provide the solution to my problem? So what's the physician unique value proposition? I think it's if you have no idea what's going on. If you have abdominal pain and you have no diagnosis and you're trying to figure that out, you don't go to a pharmacist. You should go to a family doctor, or you should go to a specialist to kind of help you on that way. If you have a clear idea of what's going on and you're taking the same medications and all you need is a medication renewal, absolutely. There's no reason why a pharmacist or a nurse practitioner can't just renew that script. But it's understanding what that value proposition is and matching the tool to the problem that you have. And I think in the course of talking about like these new mental models, we've migrated into this idea that what's most important is convenience, and to some degree, just seeing someone instead of the right someone. And I think if we shift the conversation a little bit to a little bit differently and instead ask like who can actually solve your problem, I think people would shift what they'd expect. I know for myself, if I knew I had to wait an extra couple of hours, but after I talked to that person, my problem would actually be solved, or I'd be on the path to having a clear idea of how my path would be solved, I think the majority of people would actually wait that extra couple of hours or that extra couple of days or extra couple of weeks. But we don't actually ask that question in the system right now. So we get pushed into like these old ways of discussing things. But yeah, I fully support team-based care. The Canadian Medical Association has continues to advocate for a shift towards team-based care, valuing everybody in that team. But at the end of the day, it's really the question, can they solve your problem? And if they can, we need to reshape healthcare to make sure that happens.
Okay. Okay, there's a question about that just coming up here. It says, does the focus on team-based care imply a movement away from the fee-for-service payment models?
Yeah, so there are inevitabilities that will occur. I think these are parts of the conversation that we have to move towards. And once again, I'll just go back to what I said before about what the system focuses on. It's all about cost containment, and it's about highest volume at lowest price. And that's a big part of why patient experience has gotten worse. Do I think that certain types of care, it's good to incentivize high volume? Yeah, I mean, if you're someone who is kind of who goes through a more procedural type specialty, and going through that at a fast rate leads to greater throughput, and the patient is still supported through the system to get what they need, meaning someone sits there and explains to you what's going on, they get proper consent, the procedure happens after someone explains to you what's going on, and then actually talks with you about whether or not those changes in your life can actually occur and how to support that, then yeah, that procedural type approach will continue to make sense. But there's nuance to everything. So The answer to you is maybe. And I think that's a conversation that we're going to eventually have to move into.
Okay. Okay.
Yeah.
Thank you. I'm just going to check for some more suggestions here. Oops. Okay. There's oops. Geez. Sorry. What is the CMA's view about the call for a pan-Canadian data strategy?
So 100% support. There was actually a lot of work that went into creating that pan-Canadian data strategy that we all hoped would be announced at the meeting of the federal, provincial, territorial health ministers last week. We continue to sit at tables to push forward that work. Like I'd said in a couple of the other answers, unless we move towards a learning system where we can actually get real-time data about what's going on, it's really tough for us to even know whether or not our changes are having the impact that we're hoping that they do. And so data is a core part of it, but it's also thinking beyond, the data sets that we have right now. If you look through quality improvement indicators in Ontario, for example, I think there's more than 300 last time that I looked. The majority of them are based on cost and volume. Very few talk about patient experiences. Very few talk about whether or not people feel safe when they talk to their provider. Very few talk about whether or not when they go to a place, do they have their problem solved? I imagine a lot of you nowadays, you go to try and see your family doc, you don't get in if you have a family doc. Then you go to a walk-in clinic, they're overwhelmed, you wait the entire day, give up. So then you go to an emergency, do the same thing again. It may be 4 or 5 times before you actually end up seeing anybody. Then that person may not provide you the care you need anyway. And so now you're waiting, more weeks or months in order to connect with someone. And so it's that type of data that we need to migrate towards, and having a national data strategy that, moves towards more real-time data, data that actually tells us whether or not people are having their problem solved within the system, helps us to change what we do and then evaluate whether or not our change is effective versus what we do right now, which is, we have changed. We don't know if it works, but it's changed. So everyone should celebrate it. I think that's the future of healthcare and one of the ways that we can get what we want, lower costs at the same time as having higher quality and higher patient safety.
Absolutely.
Yeah.
Well, thank you. I think we're at the end of our time for questions. Unfortunately, there's still more questions on there, but great conversation. And I'm sure this is going to carry on the rest of today and tomorrow with the patient group. So thank you so much for coming and attending, and feel free to stay on if you want and listen to what's coming up.
All right. Thank you very much.
Okay. Thank you. Okay. Over to you, Leah.
So I'd like to add my welcome to day 3 of our patient summit. I hope you've been finding it as rich and interesting a set of conversations as I have. And now it's my pleasure today to introduce Dr. Rishika Fernandopoulos. I met him first at an international value-based healthcare conference. And when he told his real-world experience of building an advanced primary care setting for his patients in the United States, I knew that it was a story that we would want to hear here. It's a story of passion, it's a story of compassion, it's a story of courage, and it's a story of really recognizing that when building primary care, as well as all the healthcare systems, it's really the patient voice and what the patient needs that has to be taken into account. And Dr. Fernandopoulos is a practicing physician and Chief Innovation Officer of One Medical, a leading advanced primary care company based in San Francisco, California. Before this, he was co-founder and CEO of Iora Health, was the first executive director of the Harvard Interfaculty Program for Health Systems Improvement, and managing director of the Clinical Initiatives Center at the Advisory Board Company. He's a member of the Albert Schweitzer, Ashoka, Aspen, and Salzburg Global Fellowships, and is co-author and editor of several publications. He serves on the staff at the Massachusetts General Hospital, on the faculty of Harvard Medical School, and has earned his AB, MD, and MPP from Harvard University, completing his clinical training at the University of Pennsylvania and the Massachusetts General Hospital. So it is my pleasure to turn you over to Dr. Fernandopoulos.
Hi, Rashika. Actually, your audio doesn't seem to be working, even though we tested it earlier, unfortunately. Hold on.
Rashika, do
Yikes,
you
you
see
are.
a little globe at the bottom of your screen? And it should say listening in and speaking in. Can you make sure they're both set to either main or original? It could be different. You're speaking, but I can't hear you. Hello? Hi, are you able to change your mic settings so that it's in main?
Or English. Another that this happened on Monday as well. You may have to select the English channel. Okay, we can hear him if we're selected in English. Okay, so everybody on our end, let's all go to the globe and select English and see if that solves our problem. Thank you, Eva. We, I can hear you when I'm in English. So everybody, if you cannot hear Rushika, click on the little globe at the bottom of your screen and select English. Thanks, everyone. Thanks, Eva. And thank you, Dr. Fernando Paul. Apologies for the tech issue. Not seeing them, so let's get back up from Axon. Oh, hold on. It's sharing now. All good. Hold on, Rashika, you're muted, but we're hearing our French translator. So, okay, you're back. No, you're good. Okay. And I'm just going to pass the microphone back to Ms. Binder in just one moment to introduce our next speaker.
I'm really delighted to be introducing my dear colleague and friend, Eva Villalba, who's the Executive Director of the Quebec Cancer Coalition, an influential Canadian not-for-profit patient advocacy group dedicated to improving the Quebec healthcare system for people affected by cancer. Since 2008, she's been involved in healthcare charities, advocacy groups, and not-for-profit organizations. In addition to her MBA, Eva is the first Quebecer and Canadian to obtain a graduate degree in value-based healthcare with a Master of Science in Healthcare Transformation at the University of Texas at Austin. She's also the co-chair of the Resilient Healthcare Coalition, has a value-based healthcare Green Belt certification from the Value-Based Healthcare Center Europe, and is their official Canadian ambassador. Eva's a fierce patient advocate and believes strongly in the potential of Canadian healthcare systems to be world-class leaders in value-based healthcare. And it is with great pleasure that I turn you over to Eva.
Welcome, Eva. Just flagging that you're on mute.
Okay, can you hear me? Can you see me? And can you see my slides?
Yes and yes.
Okay, great.
And yes.
Fantastic. So thank you for having me, and thank you to the previous speakers. I really enjoy the previous talks, and Dr. Fernando Pugliese, especially, I had originally seen during my master's program. And I think it's really interesting when we talk about value-based healthcare to look at it also from the primary healthcare lens, because there's so much that we can do there. And I think that there's a lot of promise. Today, I'll talk about specifically the role of patient advocacy organizations and a specific project that we've led here in Quebec, in Canada, and specifically how patient-reported outcomes tie into all of this, and maybe give you some ideas. I'd love to discuss with you, what opportunities you see in your own context to apply this type of approach. So I will start. So what is value in healthcare? I'm not going to do a VBHC 101 like I did a month ago during the pre-series webinar, but just to level set, when we talk about value-based care, we're really talking about value for whom? Value for patients, because when it's value for patients, it's also value for all the other stakeholders, and we want it to be a win-win-win situation. So how do we measure value? Is by measuring the outcomes that matter to patients, but over the entire trajectory of care, and looking at costs, not at one moment in time like we currently do, but really understanding the whole trajectory of care, which starts with, prevention and primary care, all of that pre-hospital kind of aspect that we currently focus too much on, and then also after, when the person goes back to their community, of course. And in traditional talks about VBHC, there's this, famous model called the Porter Value Agenda. This is like a how-to doing VBHC, and I feel that it doesn't really, it doesn't match 100% in our Canadian context. And so what we've done at the Quebec Cancer Coalition, in collaboration with various partners that I'll discuss, is we looked at this value agenda and we really thought about, okay, how does this actually translate to our Canadian context? How do we ensure that it's truly patient-driven and patient-centered? Because value-based healthcare does, kind of presuppose that you're doing everything not just for the patient, but with the patient, and measuring things that matter to them. So today I'm going to focus mostly on this VBHC implementation project that we've done in colorectal cancer in particular, at the Jewish General Hospital. And really our goal is not just to look at colorectal cancer, but actually to look at how do we create a model for optimizing cancer care in Canada? How do we actually apply value-based healthcare? Why oncology? It could be any other disease actually, but what we want is to make sure that it's scalable and that it doesn't just stay as a pilot project. So what we did is we really took this holistic, patient-centered approach to VBHC, and by having it led by a patient advocacy group with patient partners and clinicians kind of co-creating this value-based healthcare implementation, it's really a learning model. We're really approaching it as a quality improvement initiative, as an iterative project. And so it's not just a one and done kind of pilot project, which I think is important, but really we're starting to do that healthcare transformation, that culture change that we've discussed so far. And so I'd like to share a couple of insights of how it's going so far. So first things first, even before we started conceiving of this project, and the first thing we did was, okay, in order to really look at value-based healthcare in like the concrete applications of it, we first need to decide what's the patient segment that we're looking at, right? So we can't just do a one-size-fits-all model. You really have to adapt your value-based healthcare intervention or application by patient segment, or by looking at what is the shared need of a population, right? So for example, we picked colorectal cancer, but more specifically, we have to identify what are the different shared needs in colorectal cancer. So we work together with one of our member organizations, CRAN, so the Colorectal Cancer Research and Action Network. And they helped us to identify, that it's not just a homogenous group, these people living with colorectal cancer. There's early age onset colorectal cancer patients. There's those that have been screened, at 50 or plus. There's caregivers, there's survivors. And so we talked to all of them and we really identified with people with these experiences, what matters most to them. The other thing that we did even before starting our demonstration project is we had to mobilize the key stakeholders. And I think that's something that, I invite you all to reflect upon. How can you, in whatever you're attempting to do, mobilize all of the people that you need to do to enable the change that you're trying to accomplish? So we spoke to patient groups beyond the ones that were directly implicated. We spoke to patient partners. Some of them were directly implicated in our group, in our project, and others were giving us advice, even from non-colorectal cancer, just helping us to see things from different perspectives. We talked to various people in government and policy decision makers to make sure that while we were conceiving of our project, we actually were answering some questions that they might have, and we were actually making it a win for them as well. Because if we really want to enable system change, we need to have that government buy-in, especially in our public healthcare system. We talked to researchers, we talked to different collaborators, clinicians, and of course funders. And then we also did a literature review, and we actually worked in the initial phases of this project with the Conference Board of Canada. So we did some literature review in Ontario and Quebec. Are there colorectal cancer trajectories, for example? What has been done in terms of PROMS collection, in terms of patient-reported outcomes across Canada? Is there anything that's systematically done or not? So we worked on that with the Conference Board, with the Jewish General Hospital that we identified as really, which is the next step, identifying early adopters and clinician champions. So we identified Dr. Gerald Baptist and his team at the Jewish General Hospital as an establishment that was particularly innovative, that was particularly open to value-based healthcare and this like very patient-centered approach, and that was willing to kind of try this, risky type of demonstration project, applying value-based healthcare at a scale that had not been done before in Canada. So there have been some demonstration projects, or they were basically pilot projects. So in diabetes, in hearts and heart stent, cardiac stent type of situations, in hip and knee replacement. But those are very discrete, very easy to measure. It's a very linear kind of trajectory. It could be done outside of the hospital. And so it's not very scalable. We were really looking to do something in oncology so that, as we learn, as we apply it, the learnings from this can actually be scaled in other cancer types, but eventually in other disease areas, in other jurisdictions as well. And then finally, we had to evaluate, what is being done, like I mentioned, are proms being used, are integrated practice units being used, do we even have a standardized care path? And then also the readiness. So the readiness assessment that we also did with the conference board was, do we have the necessary kind of foundation in order to do this project? And so obviously we did have the basics, and that's why we continued with that. And so the main project goals were to really see what it looks like when we apply value-based healthcare in Canadian institutions. So we're documenting it as we go to make sure that we share our learnings across Canada, making sure that we develop a implementation framework so that we can actually share with others, and it could be scaled across Canada, not just ideally first in oncology, but then also in other disease areas. We also want to create evidence around the impact of a value-based healthcare transformation, specifically looking at outcomes and system efficiencies. And we're already starting to get some interesting data about that. And then finally, just to validate the implementation framework in colorectal cancer. And we're already starting to work with the Lung Cancer Institute in Quebec City to see how we can scale it up there. So very specifically, and then I'll get into the proms. These are our project objectives. The first four are the main concrete ways that we're applying value-based healthcare. Now, in the literature so far, a lot of people have just done proms. Some people have just looked at costs. Some people have just looked at their trajectory, and some people have just looked at IPUs. It is, or even dashboards. And so what we're doing is we're actually doing them simultaneously, although, and this is what I'm going to talk about next, the proms element is really like a necessary first step. But by doing them all simultaneously, they actually mutually reinforce each other. And so I'll just talk a little bit more specifically. The proms is, we were looking at how do we incorporate patient-reported outcomes measures and patient-reported experience into not just measuring for measuring, because that really doesn't help patients. And a lot of value-based healthcare projects so far, a lot of them were quality improvement initiatives. So the person today was not getting any benefit. The outcomes were looked at every 3 months. And so eventually the hospital, for example, was improving their care to patients next year. But in our project, it was very important to the clinicians that we were working with and the patient partners that when patients fill out questionnaires about their current state, that they actually get feedback pretty immediately, and that it can actually improve their own quality of care and quality of life. And so we're really excited about that, and I'll talk a little bit more about that in a moment. The other thing is the trajectory. So looking at, the whole care path trajectory, which we know is very confusing and complex for patients. First of all, it was surprising that in Quebec, there was no standardized care trajectory for colorectal cancer. So because of the project that we're doing now, the Ministry of Health has actually mandated the Jewish General Hospital to establish the standard for all of Quebec for colorectal cancer trajectory. Now, the interesting thing is that by a lot of the literature, and we're actually applying what the literature has shown us, but we're applying it in our project. By measuring proms, we can actually optimize the care trajectory. And that's part of the value of value-based healthcare. It's part of the reason why it is worth having this culture change and healthcare transformation, is by the mere fact of measuring patient-reported outcomes in real time, we can actually improve the trajectory, which means a better use of very limited resources in our, as we know, very limited healthcare setting. But at the same time, optimizing outcomes for patients. The other way that's really essential to do that, and each one kind of feeds on the previous step. So first you look at the trajectory, you identify, what are the steps who is intervening with the patient, what are they doing, and are there bottlenecks? Are there opportunities for improving? Are there unnecessary wait times? Are there excessive tests that are being done 2-3 times? Usually because the data systems, which I know is our next topic, are not communicating with each other. And so the next step is, once you have that, you can actually have integrated practice units. And what is an integrated practice unit? It is not a multidisciplinary team, in the sense that when we talk about multidisciplinary teams, it is not a team. It's actually a group of, yes, multidisciplinary specialists, but intervening not as a team, as individual professionals, sequentially along the trajectory of care. So they're intervening at specific points in the trajectory, but they're not working as a team. They're not sharing the same data. They're not talking together about patient goals or the patient outcomes. Sometimes they each have a little piece of the puzzle of patient-reported outcomes, but they don't have the global picture. And so an integrated practice unit is exactly that. It's working together with the same information, working together with the patient as part of the team, and moving along the trajectory with the patient, sharing that same information. And the goal is to actually improve patient outcomes. So that's an IPU. And so we're actually working on a framework for developing an IPU in oncology, specifically in colorectal, but also thinking of how can we extrapolate that and also do it in lung cancer next. And then the final step is with the dashboard. The dashboard has been used in Europe so far, and that's a value-based healthcare dashboard that looks at all the important elements of value, which includes patient-reported outcomes, which includes process metrics like wait times and delays. It includes clinical outcomes like overall survival, progression-free survival, things like that. And then of course, costs. And for the first time in forever, we actually have a system in the Quebec public healthcare system that allows us to at least measure most of the costs paid for by the hospital, and that will give us at least a baseline to evaluate that value. And then finally, these are more the macro kind of aspects of our project, is to use our learnings to develop a more broader framework for value-based healthcare applications in Canada. And then finally, to evaluate the impact and value for all stakeholders. So that includes, of course, patients first. Healthcare providers as well is one of our big focuses. When we say patients, we also mean caregivers, of course. And then, of course, the system and other stakeholders as well. So, why PROMS? It's because it's the starting point, right? So, patient-reported outcomes are what has traditionally been neglected. They reflect quality of life. They reflect what patients really want is not the binary yes or no cancer, for example. They want more than that. Surviving. They don't want more quantity of time at the expense of quality, right? So you wouldn't want to live an extra year in pain, but you would want to live an extra 3 months really, really well with your family in an environment with dignity, you know. And so the role of patient preferences, the role of patient outcomes that matter, that's really important. And so the first step that we did was actually a qualitative study. And this is a poster that we presented in Barcelona at the Value Institute for Health and Care conference. And also it's just been accepted at the Institute for Healthcare Improvement in December as well. And so basically we did this with CRAN and with Bridgeable, which is a service design company. And we basically spoke to patients, survivors, and caregivers of colorectal cancer to understand, you know, along the trajectory of care, what matters most to them when the emotional lens, the physical lens, the mental lens, and obviously physically, what is going through their mind and what matters most to them. Now, we had to do this first because the second step was actually, we did this with the conference board and with the Jewish General Hospital. And this is a poster that we just presented at the ICHOM conference in Boston a few weeks ago. We basically looked at the ICHOM standard set. So an international standard set of what should you be measuring when you're looking at colorectal cancer patients. And then we compared it to what they were actually measuring at the Jewish General Hospital. And it turns out, not surprisingly, we were hoping that the conference board would have published their report by now, but it should come out by the end of the year. So it will be public soon. But basically what came out of this, and that's the poster presentation that we presented, was when you ask doctors, okay, here's the wheel from ICHOM. These are all of the things that we should be measuring. Do you measure these? Yeah, we do. Yeah, of course we do. Yeah. So that won't surprise you that when we actually checked in the registry and with the registrars and with the people entering this in the databases, there were a couple of not so surprising facts. Number one is that they were fragmented in about a dozen different databases. So there's no aggregated way of looking at all of these proms all together. The second thing is that out of everything that could be measured, the things that were not measured corresponded exactly to what we had found in our qualitative study of actually talking to patients that were more important. For example, dietary restrictions and issues with incontinence or digestive issues, things about sexual health, things about emotional health and issues with their relationship. And so all of these things that were important to patients were exactly the things that were not being measured. And so the positive outcome of all of this is that thanks to this kind of foundational work of our project, as of now, the Jewish General Hospital is going to deploy all of these proms in their trajectory for all cancer patients, for all colorectal cancer patients. And so we're working actually on a proms tool to not only measure patient-reported outcomes in real time, but to give patients a response immediately in terms of some written information that they can access in terms of, let's say, okay, if you have constipation, this is some helpful tips that you can do in the meantime. But more importantly, they will get a follow-up within 24 to 48 hours with a nurse. And that seems to really work in terms of improving outcomes in the short term. And just yesterday, we spoke to a doctor from Belgium who had done the same thing in lung cancer, and they were able to increase the overall survival of their patients with stage 4 lung cancer by over 150 days, which is incredible. It's better than some medications, by simply measuring proms and acting in real time to improve the trajectory of care. So that's pretty exciting. That's exactly what we're doing in our project. So that is the power of measuring proms in real life. So some other learnings as we're going along, we're not just, Quebec has a tendency sometimes of, in French, we say, looking at your own belly button and kind of not looking out. So we're doing the opposite. We're really using our extensive international network and learning from best practices elsewhere. So like I mentioned, we spoke to Professor Demetz from AZ Delta in Belgium about their applications in Belgium in lung cancer. We had a presentation from Santion in the Netherlands. They're really the best in terms of this dashboard of VBHC. And so they taught us a little how they were using it. And also proms can then be used, and this is what Santion is doing, and this is where we would like Quebec and Canada to go as well, is based on those proms, after you have enough data, about 3 years of data, you can actually use that to enable shared decision making and show people, okay, you're a 45-year-old woman with breast cancer. These are your 3 options. Other people like you had, this type of side effect with treatment A, this type of side effect with treatment B, and this type of side effect with treatment C. This is the level of efficacy. This is the quality of life. What would you choose? That type of shared decision making is something that we, for now dream of, but it is within reach, and this type of proms work is really the way to get there. We also have good collaborations with the Livestrong Cancer Institutes in Austin, Texas. They have been deploying value-based healthcare in oncology and specifically in GI, so we're really working closely with them. The Center for Excellence on partnership with patients and the public from the University of Montreal is a big collaborator of ours, as is the Learning Health Systems SPORE unit. And so we're really integrating these aspects as well of patient partnership and learning health systems into our value-based model. And so I'm just checking the time, making sure I'm not, okay, good. I think I'm good in the next 3 minutes. So finally, next steps. So the next steps is, this is a 2-year project. So we started in February of 2022. As of February 2023, we're actually collecting the data. So we've established the baseline, the trajectory, the IPUs, the proms, and the whole kind of algorithm for the proms that we're using Qualtrics as a platform, but really it could be any platform. And then as of February, we're actually doing the data collection and aggregation and learning from what comes out of that. So we're looking at the impact on proms, and we're going to be looking at things like ER visits, time at the outpatient clinics. We're also looking at reducing health inequities in the sense that, you know, traditionally, we don't even, as you know, we're not measuring the right things. We're not even identifying like who's falling through the cracks, who does have poor outcomes, and then why. What can we do to actually fix them? So that's another one of our objectives. The tying the costs to outcomes has never been done before in the Ministry of Health, and they're very interested in seeing how we do that so that they can then scale that. We also need to see how we're incentivizing value over volume, because actually currently our system rewards volume. It rewards healthcare services, not health. And so we really need to look at like, what are we incentivizing and what are the outcomes right now? You know, for example, we're looking very much at cost of medication. We're not looking at cost of treatment. If we look at treatment in its entirety from end to end, we would be making different decisions, but we need that baseline information, which is what we're doing. And then I spoke about the VBHC dashboards and, you know, scaling up these integrated practice units. So like I said, we're going to scale to other cancer types. Lung cancer is next, but we're thinking, you know, always of other things. And this is one of the reasons why I'm glad to be sharing this today with you. I'd love to hear, you know, opportunities that you all have across Canada. We're very open to sharing, you know, with other institutions as well. But right now, we're really well poised because of the government relations that we've done in advance of this project and throughout this project. It really inscribes itself really well with the announced healthcare reform in Quebec, which is very value-based actually. And so they're really looking at us to see, you know, how they can learn some things from our project and then scale it to the larger healthcare transformation, which is happening in Quebec, and then, you know, hopefully have some repercussions in Canada. And then finally, you know, we have started already, and we will continue to publish, present, and continue to involve patient groups and people with lived experience at all steps. I don't know if it was clear enough, but we have had patient partners co-creating the methodology, and every single step of the way they've been with us. We're not doing it for them, we're doing it with them as well. So I hope that was it. I think I'm on time. So if you have any questions, I'm happy to take them.
Eva, thank you so much. You did a fantastic job of summarizing such phenomenal work. And I really thank you for your presentation, and excited to get us started on Q&A for your presentation. So if anyone does have any questions for Eva, please do put them in the chat. There's one there now, so I'll start with what's there already. Excellent presentation. Who will own the PROMS data? Are there data sharing agreements between institutions to gain longitudinal data? It's a great question.
That is a great question. So it's really important for us. We actually have no interest in having any of the identifiable data. So all the data stays at the hospital. So the hospital staff, the clinicians, are the ones looking at the data, and then we just get the kind of aggregated, anonymized data. So we help on creating the dashboards in terms of what should be on there, but then what's actually in the dashboards and who is in there, it's like none of our business, and that's not that the hospital does have that information, and the ministry will have that information. We're also talking to, you know, like Ines could have that information if they're interested in having it. The RAMQ, like we have been talking with the government and the people in charge of data to make sure that the people that need that information have that information to make proper decisions. But we're more interested at the macro level, like what are the basic fields that should be in there? You know, what outcomes matter to patients, and making sure that those are actually included and not like, it's always a nice to have and then they get left out, but those are the ones that patients actually care about. So we're there to kind of advocate for that. But very importantly, the individualized data never leaves the hospital. So,
fantastic. So it's, yeah, it's a great question. So it's clear that it's under the same structure of privacy that the hospital follows. Great. We have another bravo and a question. How can we as a network help amplify your work during the ongoing process with decision makers in other jurisdictions? Example, possibly start planting seeds.
Yeah. So I have been thinking about this a lot lately, and like, you know, we've been talking a lot as patient groups about, you know, this latest PT health ministers kind of meeting and all of that. Like, so I think one of the things that as patient groups and as patient advocates that we can start doing is really advocating for measuring outcomes beyond, you know, right now, what are we measuring? We're measuring volume of services and we're measuring costs only of medications, not even of like excessive hospital stays, for example, right? Or of complications. So I think one of the things that we can do as patient groups is really lobby for greater use of prompts. So at first, you know, a couple of years ago, there was a great reticence of like too much resistance to any kind of change in terms of measuring outcomes, because the automatic assumption is that it will actually add a burden on clinicians. And it's a very legitimate concern, okay, because they do a lot of paperwork that is not value added. However, and that's the point of our project, is to demonstrate that by measuring outcomes, it is a good investment of the patient's time and of the clinician's time, because it actually improves outcomes and diminishes, you know, unwarranted resource utilization, for example, like excessive, you know, emergency room visits or things like that. And so I think that lobbying for that, now that we're all talking about data, and I know it's coming up, you know, to really ask for the right type of data being measured, and that we ask for a longitudinal vision, a long-term vision of evaluation of value, and not like a discrete sequential kind of measurement of like, no, this is too expensive, let's just avoid doing the diagnostic test, you know, and like maybe if the person is alive after 4 lines of treatment, then maybe we'll give them the right treatment, you know. So it's like it's that kind of reflection, which I think we can all take part in, that I think will make a big difference. And with the federal health transfers, I think we can suggest that people that provincial and territorial jurisdictions do share some of those key indicators of value, you know, beyond the clinical, like beyond just incidence and mortality, and like how much does a medication cost. There's a lot more important things that we should be measuring and sharing transparently, because that does help with confidence in the system and trust that we need.
Fantastic. Thanks, Eva. I'm hearing little bits that can be used for our working group discussions tomorrow and for future, especially that advocacy piece. It's really important. So we have another question for you. Eva, given the situation with the provincial health minister's reluctance to share health data with the federal government, is there a way we can push this? I think you kind of answered that a little bit. So I don't know if you have anything else to add to that, but I hear you loud and clear about advocacy, but go ahead.
Yeah, no, I think I did cover it, but maybe Cheryl-Anne was writing that while I was answering. But I think that we really do need to encourage greater transparency of data sharing at the provincial territorial level. Yeah, the provinces should be able to do what they want, but at the same time, can we all agree explicitly, because right now it's implicit, like what is the mission of our healthcare system? It should be to provide health. But if that was the case, we would invest a lot more in prevention, which we don't do, right? So, and we would invest more in social determinants of health, and we would invest more in, you know, healthy, what do you call it? Lifestyle kind of prevention stuff, right? So in reduction of environmental factors that cause different diseases. So I think we do have to kind of keep hammering the same kind of message, that we do need outcomes, but quality of life outcomes, and standardized. So what's very important in value-based care is that there should be it's kind of the 80-20 rule, the Pareto principle of like, there should be standardized measures, but then what's important varies. So it's like 80% standardization, 20% personalization. What matters to you might be different than what matters to me, but the measures are going to be the same. It's just that, I might care more about, having the energy to do all of the things that I need to do. And you might care more about, ensuring that it doesn't affect your mental health, or that it doesn't affect your fertility because you're planning to start a family soon, or, but we're all going to get all of those questions, but some of them might be more important to you. But I think what, as patient advocacy groups, we can do is really keep insisting on using the existing validated PROMS measures that do exist, but then also convincing, which I know, and we've talked about this in our PROMS working group, sometimes clinicians are actually reticent to use standardized measures because they think they already know what patients need and want without asking them. And that's what I think we have to fight against too.
And yeah, and I would add, like, to your point during your presentation about when you ask healthcare professionals, are you asking these things? There's like a yes, of course. And sometimes it's like that reflection, right? Or that like stepping back and actually questioning, like, are you and how are you and where is this information going? So it's not necessarily like a not wanting to, but there's really just some assumptions, I guess, too, that we have to challenge that of how people are doing things. So great points. I have one of the things that I loved that you said over and over in different ways, Eva, was how you're looking at colorectal cancer, but this is something that you're going to think about for lung. This is something that you're thinking about scaling, and how can this be applied to other cancers? And it's really aligned with some of our thinking in this summit, which is like, we have to help each other, right? We advance each other and we make each other stronger. So I wonder, so we see a how can we scale question that you can maybe speak to a little bit, but I also wanted to know, like, is there a place that's public, a little like a community of practice or some sort of repository of these types of projects that are happening around value-based healthcare that's accessible to others to inspire us and to kind of keep us in the loop about where we might be able to get more information from people like you?
So it's a bit of a conundrum because in Boston at the ICHOM conference, we actually had a great Canadian delegation breakfast. We were like, like in Hollywood and in music, like Canadians are always overrepresented in terms of our tiny population. We have like good talent, right? So in value-based care, we actually had a great showing. And what I was really happy to see is that even the Quebec government people came en masse. And so we were like this huge Quebec delegation. There was a really big Canadian delegation from, coast to coast, like really Atlantic provinces, BC, and everywhere in between. So there is this momentum growing in VBHC. Now, is there a repository that's public? Unfortunately, not really, in the sense that there is VBHC Canada, which is a part of the conference board. They have some publications which are public. They were supposed to have a repository. I don't think it's happening finally, but there is momentum growing. And so I think that, honestly, I mean, I know I'm kind of annoying about this, but LinkedIn is a great place to follow these people and to get some information about what these things are happening. I'm super happy to share and kind of connect people with other initiatives happening. Like I said, there's great initiatives across Canada. Kai is doing some work, limited work, but they're doing mostly hip and knee. And then there's other, initiatives happening here and there. I think that we're the first project that is really like end-to-end VBHC application. And what I think is exciting is that it's really patient advocacy led. We're also doing another really exciting project with Myeloma Canada to build a new standard set with ICHOM for myeloma, multiple myeloma. So I think it is moving, and basically I'm cheating here, but I think one of the takeaways that I would like you to have is that as patient groups, we have huge impact in actually transforming healthcare. I think that in Canada, we live in a real democracy where we can actually really influence our decision makers, and we're respected because we deserve to be respected, because we really work, with and for the people that we represent. But I think that we need to use that opportunity, and in value-based healthcare in particular, I think that we're more innovative, we're more agile. We actually see things from the patient perspective, but also the healthcare professional perspective, also the public payer perspective. And I think that we're well positioned to actually, wherever you may be in Canada, kind of promote that approach and promote that collaboration. And so I think we're really well positioned. I think this is like a great opportunity for patient groups.
Amazing, thank you. And more food for thought for our working group sessions about how maybe we can start putting some information together that's accessible. But there's another question, and then we'll wrap after this one. And the question is, how do we ensure that VBHC doesn't inadvertently lead to clinicians avoiding taking on complex cases for sicker patients? A while back, this was an issue in surgical services in the US, if I recall correctly. Great point. And yeah, if you can talk about some of those challenges.
So in the application of value-based healthcare in Canada, and I had some very heated discussions about this in Boston recently at the ICHOM conference. The reason that did happen in the States, okay, and it was because they care so much about the making money off of the patient at the end of the day that they were trying to cut corners. Okay, now a real value-based healthcare model, like the one that Dr. Fernando Poole was talking about, they basically say, this is how much we're going to pay you for a patient, get the best outcomes for this cost, right? And they have these bundled or value-based payment models. Now, normally you're supposed to hit those objectives, but some people try to just cut costs without hitting the objectives. In a true value-based healthcare models, you would be penalized if you don't attain those objectives of quality of life, of clinical outcomes, if you just cut costs. And so there is case mix variable weighting, so to avoid that bias of like only taking easy patients. But I would say that in Canada, in the model that we're going to propose, the cost is not as important as the resource utilization. So we're not actually trying to cut costs. We're actually trying to keep the costs at least stable, but use not less resources, but better resources. Like, is a doctor necessary at every single point? No. In Canada, we're lucky. We have, primary care. We have nurses. We have pharmacists. We have clinicians of different kinds that can actually intervene. It doesn't always need to be on the shoulder of the doctor. And so that redistribution of resources and attaining better outcomes is another way of attaining better value. So it is a legitimate concern. And so we really need to build it in and make sure that we're not just looking at cutting costs or taking easy cases, but how do we maintain the same type of patients? And in fact, they're probably going to get more complex because with the aging population, with all the comorbidities, they will probably get more complex. And so there are different approaches that we can take in value-based care, which is like more value managed care for like the frail elderly population, for example, that has like many comorbidities, but I won't get into those things. But the point is that there is an approach that enables us to not fall into that trap, but only if we're aware of that trap. So again, with the mental models that Dr. Lafontaine was talking about. So I think that, it's definitely an important consideration, but I think that we can avoid it if we keep it in mind. So.
Excellent, thank you. And thank you for raising that question, because the only way that we keep it on top of mind and keep aware of it is that we keep challenging each other and we keep questioning these things, because it's a great point, and we don't want to do anything inadvertently that's going to kind of keep more of the same for complex situations in health. So thank you, Eva. You're always the best. We really appreciate all your work and your being here today to present on it. And we look forward to updates as the project goes on. So thanks so much. And it's my absolute pleasure now to invite our panelists for the final panel. I hate to say this, but it's the final panel of our summit. I'm enjoying them so much. But if I can invite those of you who are on this final panel, please turn on your cameras and get cozy because we're in for a treat from your presentation. And it's my pleasure to introduce the panel and short introductions of each of you. The recognition that health data, including our personal health data, are foundational to health outcomes and evidence-based decision-making has never been more magnified than at this moment in Canada. These data include everything from patient data from electronic health records, clinical trial data, trial results, data for health technology assessments, price negotiation, and real-world evidence generation, approval surveillance of devices and treatments. Many decision-making and evidence-generating stakeholders are developing data collection and sharing processes. This was a huge part of the discussion at the recent federal, provincial, and territorial ministers of health meeting, as we know, at which the federal minister of health proposed additional Canada health transfers to provinces and territories to collect and share data through the creation of a pan-Canadian health data strategy. Unfortunately, no agreement could be reached, with provinces reported to consider that they have jurisdiction over provincial data and that the needs of each province and territory are discrete. Well, here's where our panel comes in, because I'm sure there's going to be some important challenging and insights from them. Again, I'm not going to read everyone's bio. They're up on our summit page, but I'm going to do a quick introduction of those who are speaking today. Linda Wilhelm and Terry Price are two patient and caregiver experts and advocates sharing their lived experience of the harmful impact of the lack of personal health data sharing. We have Elise Maybe, a patient advocate, and Eric Sutherland, until recently, the lead for the Public Health Agency Pan-Canadian Health Data Strategy. They're both leaders in developing the expert advisory group reports under the auspices of the Public Health Agency of Canada, or actually that's Eric, but they are both experts and leaders in this discussion. Jenny Barnes and Barney Ouliette are colleagues from the NHS in Scotland and Catalyst IT to describe implementation of their data management strategy in the region of Tayside, Scotland. And we have Shanil Patak, the Summit Data Working Group Chair, to talk about what we can do now as patients, caregivers, and engaged citizens, as well as the groups representing us to advance some of the things that the panelists are going to be talking about today. So I will turn it over first to Linda and Terry. Thank you all so much for being here. I'm really excited to hear from you.
Thank you, Antonella. I'm not Leah Stevenson. I'm Linda Wilhelm, and I'm happy to be here. Coming from a province that is way behind on this with accessing my data. I live in New Brunswick, and the only thing I can access online are my COVID-19 vaccines. There's a wonderful My Health New Brunswick app that they developed, and I'm sure they spend a lot of money on it. And it just seems like such a waste to me that I can't access my blood work or my x-rays. I'm a bit of a control freak, having lived with rheumatoid arthritis for almost 40 years and have experienced a lot of the pitfalls of the system where I've had to be responsible to coordinate my care and to make sure that, you know, that one specialist and another specialist and my family doctor and everybody knows what's going on. And it's extremely frustrating. I've gone in to check appointments and, you know, with my phone, and I'll take pictures of things, and God forbid should the doctor leave the file sitting on the counter and leave the room, because I will look at it. But I always feel like I'm sneaking and as I'm doing something wrong, but it's my data. It belongs to me. It's all about me. I've had so many experiences where special authorization for medications that are life-saving for me have not gone through because the pharmacist, the NB New Brunswick Drug Program, and my doctor all communicate, but they leave me out. So I have no idea. I've gone to the pharmacy to pick up a prescription and said, oh, that'll be $1,600 because I did not get my special authorization approved. And so then it's backtracked to try to figure out. And I've learned I've had to stockpile. I've had to stockpile medications because I always want to have a month ahead just in case there's a glitch in the system. I deserve to know what's going on. And honestly, in a day like today, where our healthcare system is in such a turmoil and so stretched, it's dangerous. It is absolutely dangerous for patients not to be able to access their records and to be able to bring them with them when they go to appointments. And it's so frustrating. And I watch the meetings like everybody else, where the ministers, the provinces don't want the federal government to tell them what to do. And I was really excited to me that, yes, please, federal government, make the provinces to put this money where we need to have it. We have virtual care now. We have telemedicine now. All these things, there's so many balls that can get dropped, and patients' lives are going to be lost because some communication has not gone through that a patient could have caught. So that's my story. It's not a happy one. It's not a positive one. It's a frustrating one. But I'm going to turn it over to Terry, and I'm sure she'll add to that.
Yeah, thank you, Linda. And yeah, so I'm joining today from Calgary. I'm Greg Price's sister and currently the executive director of a not-for-profit organization that we stood up in honor of Greg. The organization is called Greg's Wings Projects. And the first major project that we took on was the Falling Through the Cracks short film, which we've used over the last 5 years to spark lots of conversations about healthcare broadly. But the topic of information and data sharing almost always comes, I can probably say always comes up. So just to back up a little bit, Greg was a mechanical engineer. He had just turned 31. He had been pretty healthy his whole life, was somebody who was super intelligent, loved to learn, loved to challenge. And so, and he had testicular cancer. It went undiagnosed and untreated for a long time, well over a year, from when the first sort of symptoms were flagged. But his journey through the healthcare system was really individual interactions between individuals without the sharing of information or any kind of true teamwork. And so when he died, we really wanted to understand what happened and if there was things that we could do to help to prevent it from happening again. The Health Quality Council of Alberta ended up doing an investigation, which was one of the sort of major milestones that I keep, I think, for our family in our learning about the healthcare system. Like a lot of members of the public who haven't had a lot of experience in healthcare, we made a lot of assumptions. We assumed that healthcare was relatively safe, that we could rely on it when we needed it, that the system itself did everything possible to support everybody in delivering safe care and patients receiving safe care, and that would include the sharing of information. And I think that's not uncommon. I think people do, and we know this from the conversations we have after the film, that a lot of people assume that when you go into the emergency room, they can see the notes from the family doctor, or when you go, that you're in the emergency room, your family doctor gets notified, or any of those sort of, there's lots of different examples of where that generally assumed information was being shared. We assumed that safety was a priority for the system, that it's always top of mind. That the system will do anything possible to make safe care possible. And we also know that that's not necessarily the truth across the board. It always amazes me the number of times that we talk about different initiatives and change in healthcare, and it's not grounded in the need for safe care. And that includes changes around the sharing of information and data. Can we really expect healthcare providers to be making safe decisions every time when we know that the entire care team doesn't have access to the same information? And that happened multiple times in Greg's care. And over the last, so the HQCA report was released, well, it was 9 years ago, but Greg died 10 years ago. And so over the last 10 years, we've learned a lot. And really there's a few priorities or sort of focus areas that we really believe in. One is the need for teamwork in healthcare and true teamwork. And we need the systems and the mindsets. And I've heard Alika speak a couple times, and it always really resonates strongly and is so helpful to hear his perspective. But we really do believe in the need for teamwork in healthcare in order to deliver safe care. And then in order to have teamwork be possible, we need access to everybody on the care team needs access to information and the ability to communicate between the care team. And that includes patients and families. It's not the sort of care team or all the providers and the patients and families are the passive receivers of care. That's not the model that we think about. And so we need both that shift in mindset to recognize that what teamwork is, how critically important it is, what is required to actually enable effective teamwork. And that's both a shift in mindset, but it's also system change. And I actually don't know which one needs to happen before the other, whether or not we change mindset so that we can advocate for the right kind of system, or we change the system so that when people start to recognize that things like teamwork are important, it's not sort of rolling a boulder uphill in making the efforts to make teamwork possible. We also have thought a lot more about sort of the different different levels of the system where teamwork is required. We really believe in the need for teamwork for the patient's care team. But I think some of what we're talking about today around the advocacy and change in the systems, we also need that mindset around how critically important it is to collaborate across systems. And so that's sort of that same teamwork mindset at the system level, and that everybody has a role to play in speaking up for the kinds of change that we need in the system. And we need all of the diverse perspectives. We need patients to be heard and to be at the table, and the different perspectives that patients have, because we're not all the same, but also the support of the different providers and recognizing the expertise that they bring to the table as well. But that no single person or group or organization is going to actually be able to accomplish the kinds of change that we need. We need to recognize that we have to be collaborating, which to me was one of the biggest disappointments of the breakdown of the talks that we've already referenced today between the provinces and the federal government. Is I think that those breakdowns, without knowing a ton of detail, was probably more about negotiating who has power and control over what, versus the recognition that we need to be collaborating and that we will have a better healthcare system in the country if we actually work together. I'll maybe stop there. I knew that this was going to happen after listening to the talks this morning, that there's so much that that is inspiring and exciting, but I'll maybe stop now and hand it back over, and I can jump in the panel discussion if it makes sense.
Amazing. Thank you so much, Terry. That was so powerful. And Linda, we are so grateful for you sharing your difficult, in many cases, stories. And so I'll turn it over to our next speakers, Elise and Eric. Thank you.
Okay, so I'm going to sort of pick up from where Terry and Linda left off with their really clearly articulated personal stories, and sort of go up a level, if you will, to look at this from a systemic point of view. I'm just going to share my slides if I can. There we go. Can you see that?
Yes, we can.
Great. Okay, so I'm going to be talking really about the current unhealthy state of our health data in Canada, and hopefully end up on a slightly more positive note. Oops, sorry. Okay, so I've been a patient partner since 2011, but one of the most exciting and interesting things I've done is over the last 2 years, I've been on the expert advisory group for the Pan-Canadian Health Data Strategy, along with Eric. So I will be referencing that as I go forward. I'd like to sort of cover off a couple of things. First of all, why is health data important? Then I'd like to kind of touch on what is a healthy system, because we need to have a vision of a healthy system if we are going to understand what parts of it are really unhealthy. And then I will look at some of the root causes of our unhealthy system that are really based on the work that we did in the two first reports for the Pan-Canadian Health Data Strategy. And I'll touch on a prescription for health system. So just quickly, personal health data is all the stuff that we're used to. It's the clinical data that gets dumped into our charts. It's about symptoms, diagnoses, and treatments. It's the results of all the tests that we do, blood work, x-rays, and all that sort of stuff, and the prescriptions. But it's also expanding. And as we go along, the type and quantity and sources of our personal health data is growing. It'll grow to include things like genomic data, wellness app data, data from remote patient monitoring, and many things that we probably haven't even thought of. It's also data to manage the system. So governments gather all kinds of our data from the billing and admin systems, and they use that to manage the single payer systems that we have in this country. And governments, health authorities, and researchers also use survey data that is also considered health data. Researchers gather information from patients specific to their inquiry, and that too is health data. So we need to understand sort of the scope of health data. So now, why is it important? Well, to me as an individual, the data are us in the system. They're a reflection of us as individuals. And they're also the essential ingredient that our clinicians use to determine what's wrong with us and how to make us better. So we better be concerned as individuals about health data. On a collective point of view, our collective health data is lumped together or aggregated, and it's used to figure out what to do with the health system and forms or should form the basis for policy and practices that improve health for us all. It's also used with consent to fuel the research that ultimately leads to better practices or better treatments for targeted populations. So as a member of society, we better pay attention to health data in the aggregate as well. Now I'd like to really spend a little time imagining a healthy system from a patient perspective, if you will. So, treats me and where is my data? I'm one person, but my data is fractured all over the system. There's snippets of Elise Maybe everywhere. And why is that? Because we have a provider-centric data system. All the efforts to give us patient-centered care are going to be flying in the face of a system that is not designed to support that. So when we think about our primary care providers who are trying to solve our health issues with insufficient and incomplete data, no wonder they're stressed. Most of us want one place for our data. In effect, we want one record or one view of our data, one instance of me, not multiples. I want one portal, not one per provider. I have now 4 or 5 of them. Currently, the onus, and I think we heard this really from Linda, the onus is on us as patients and caregivers to stitch together our information so that we can figure out what's going on and then share it back to the clinicians that we deal with. We want the system to take that job over. This is a fundamental structural issue. Most of us want the data to be shared with our care teams, and this is something that Terry was really talking about too. We need to share our data, and we do so manually now. Some of us walk around with it on our phone, so we bring it to the doctors that way. Some of us lug binders of information from clinic to clinic in order to share life-impacting information. So right now, it's on us as patients and caregivers to access, collate, and share our data. I mean, really, what if I'm really ill? How do I do this? What if I don't speak English well? How do I do this? What if I'm homeless or running between multiple jobs? How do I do this? This situation bakes in structural inequality into our systems. And then for clinicians, if we had a system where they could see everything, they wouldn't have to spend time chasing data, fearing that they don't have adequate data to help us. It might relieve some of their stress. So in the end, we want to take the burden of data sharing off us and change the system to do it for us. Currently, our data is dammed up and doesn't flow on a timely or complete manner from care site to care site. And some people in Canada receive their health services in more than one jurisdiction. So if you think about like Ottawa-Gatineau, or people who live up north and fly south to Edmonton, Ottawa, and different places like that, or people in Manitoba who come to Thunder Bay. A lot of us cross jurisdictions. If we can't share the data, isn't this a safety issue? Let's talk privacy, or who decides who sees what. Health data privacy is currently controlled by custodians, which kind of conjures up the view of jailers. And jailers don't usually like to let the data out of jail. As a health system, we haven't really thought adequately about the harms of not sharing data, the kinds of things we learned from Terry, for example. The privacy seesaw needs to be rebalanced. Most of us want to share our data for the greater good. We're a rather benevolent society, I think, but where this becomes a bit sticky is when there are third-party private sector players. And this raises a bit of a concern about selling our data for profit. But we can address this with appropriate legislation and transparency to the public. We want to share, just make sure that we are protected. There are a lot of harms from not sharing data. This is a safety issue. Patients experience risks, and again, we've heard earlier about what some of those risks are, including death, as we've seen from the stories that Terry and Linda have shared earlier. And some of those harms come from systemic issues like the lack of data sharing between providers, between sites of care, between jurisdictions, and importantly, with patients and their caregivers. Clinicians need complete and timely data to treat us without inadvertently causing us harm. If not, this is both dumb and dangerous, and it's harmful to patients. So now I'm going to take a bit of a deeper dive into the unhealthy state of our health data by looking at the symptoms or root causes that we found in the Pan-Canadian Health Data Strategy first two reports. So this is our current state. Due to the weak foundation for data collection, sharing, and use, we have a public that's frustrated with lack of access, as Linda so eloquently indicated. We have First Nations, Inuit, and Métis suffering from health systems that perpetuate and contribute to existing structural social inequities, and that applies also to other diverse communities. We have a public health that doesn't have ready access to all the data in a timely and actionable way, as we've seen with the stutter starts for helping us through COVID. We have clinicians who are challenged to incorporate new requirements and don't necessarily see any benefits or reduced workflow. We have a healthcare sector management who is frustrated and uncertain about how to address data shortfalls, which leads to below average results and above average costs if we compare with the G7. We have researchers who spend significant time obtaining data access and sharing approvals, and this kind of delays their work to the point where it must be enormously frustrating. And we have innovators who have great ideas and they can't be implemented or scaled due to the fragmentation of our health data ecosystem. So that's really our current state. As you'll note, it's a frustration for pretty much every stakeholder. Jurisdictions and organizations each have their own view of things centered in themselves. They do not yet share a common vision of a person-centered system overall. And some of the ways that we see this lack of a common vision are the lack of consensus and follow-up on interoperability, the failure to spread and scale excellence, and we do produce excellence in this country, we just don't get around to sharing it much, misaligned incentives, and an uncoordinated approach to procurement and implementation of digital health solutions. And there are others. Healthcare in Canada suffers from cultural paralysis. due in part to a huge desire to protect the status quo that Dr. LaFontaine was talking about earlier. Well, that won't wash any longer. It's very clear, I think, to all of us that our system is broken in more ways than just with the health data. So perhaps we better try a different approach. The current treatment is not working, so we need a new treatment. This cultural paralysis shows up in different ways. In the risk aversion we see everywhere in healthcare, in the culture of avoidance, in antiquated, analog-based data policies, and in fiscal pressures that focus on the front line but do nothing to look at the systems that support and enable the front line. So where is the public involvement in this, in matters of health data? There is limited public insight and involvement, and this shows up in a lack of trust on the part of the public and patients and caregivers. And it's compounded by a lack of clear accountability for our health data. So while I don't want to steal Eric's thunder, let's look at an overview of a way forward based on the Health Data Foundation. So we sort of end on a positive note. The foundation starts with a common vision, and it's a vision of an ecosystem, not a centralized technology solution. This is about technology. So by 2023, all persons living in Canada will benefit from a fully integrated and continuously optimized health data ecosystem that honors data ownership and collective quality care through the cooperative use of individual and aggregate health data. So that is the proposed vision. The common vision is kind of like a North Star for the Health Data Foundation and should be adopted across all jurisdictions. So from this vision flows 5 foundational elements: federated data governance with clear accountability, meaningful engagement with public that builds trust, effective policy environment for the digital age, clear standards for interoperability, and greater health data literacy across sector and the public with a common language so we can all speak the same language when we're talking to each other about these issues. And there is, I think, this is not, it should not be understated. We need greater public health data literacy, and we need it across the sector as well. So now, how to get where we go? Here are some of the actions that have been articulated in our reports that we can take now. Establish federal, provincial, territorial governance and align it with First Nations, Inuit, and Métis data governance. Engage the public and the First Nations, Inuit, and Métis to understand what the requirements are. Develop health data policies that deal with the current digital environments. Develop, identify, and agree on health data interoperability standards. Develop, identify, and promote health data terminology and literacy. And we need to move to a person-centered data design. Where we are now is on the left, and that is the analog digital combination for 2021. Providers here act as custodians of digitized health records, and barriers make it difficult to share across silos. Much of the health information exchange is still by fax, and patients are outside with modest access to their data. What we need to move through, a future state, if you will, is a person-centered data design, and this provides the right data to the right people at the right time by design. It uses up-to-date technology to manage the data exchanges, and the patient is at the center and has access to and control of who sees their data in concert with the data steward. So I'd like to thank you for the opportunity to talk about this and to leave you with 3 thoughts. First of all, It is urgent that we do something, and the time is now. We're in crisis and we need to act now. Secondly, we need a common vision that is an essential core element to the Health Data Foundation. And finally, we need person-centered health data by design. It's the key structural element. So thank you, and I look forward to the discussion with the rest of the panel.
Thank you so much, Elise, for a great presentation, taking us to the macro level of some of the issues that we talked about in our first presentation. So thank you so much. And I actually made a mistake. So Eric, you're not next, you're on pause, and we're gonna go across the pond to our speakers. I'm so happy to have you here, Jenny Barnes and Barney Ouellette. I'll open it up to you. Thanks for joining us today.
Good afternoon, or over here on this side of the pond, good evening. Lovely to be here talking to you all. I'm going to try and get technology to work and share my screen, and Jenny and I will put some slides. Okay, here we go. Hopefully that's now visible on the screen for you.
It is, thank you.
Super. Okay, so my name is Barney Ouellette. I'm on the bottom right, as you can see there, and I work for a company called Catalyst BI. My background is actually, I used to work in the NHS in the UK for 13 years in data, performance management, data quality, data literacy, and so on. I'm here with my colleague, Jenny Woods. Are you there, Jenny?
Yes.
Hi, Jenny. Unfortunately, we can't hear you. What you might want to try to do, if you see the interpretation globe in the bottom of your screen, perhaps try selecting English. Maybe that'll solve the problem.
I can hear Jenny really well.
Oh, okay.
Yeah, so if everyone wants to make sure that they're on the English option under interpretation, if you want to listen in English, because I can hear Jenny loud and clear, and it seems like, yeah.
Okay, I can too now that I'm in the English mode.
Super.
Okay. Yeah. Nope.
Wow,
that's not your fault.
Technology, brilliant. I never knew that existed. So yeah. Right, Jenny. And hopefully today, what we're going to talk to you about is sort of the relationship we've had over the last few years in trying to sort of collaborate, bring data together to actually help the entire sort of health economy up in Scotland at Tayside, by how how using data can actually be a really, really positive experience. And hopefully you'll see as we go through these slides sort of how that collaboration actually provides a lot of benefit. There we go. So that's where we came in. So Catalyst BI, but actually crucially in collaboration with UHMBT, which is University Hospitals of Morecambe Bay NHS Trust, and obviously Jenny and team at Tayside. And that collaboration is key. So at Catalyst, we're a solution provider. So we work with people to create solutions that hopefully fix problems and obviously deliver value. We are not experts in what's needed by NHS organisations. So that collaboration with University Hospitals of Morecambe Bay to help create that core solution provision, and then working with Jenny and team at Tayside to then kind of tailor it around their needs is absolutely critical in order to make this a success. We don't want to create something and then tell people you've got to shoehorn your process into our system. It's about creating a system which works around your requirements and needs. You can see some really key sort of facts here as well. So the senior managers at Tayside were actually involved from the start. Clinicians, managers and so on, really, really crucial to that success. You need their buy-in, you need them to be involved in the journey. So it doesn't just feel like another system that's thrust upon them and there's negativity and so on. If they're actually part of the journey, they're far more in tune and more engaged with that when it actually comes to sort of fruition and live. It's a really, really quick deployment. Now, obviously, I'm going to say that we provide it, but it honestly is. The way we've designed this thing is we've literally lifted a lot of work from University Hospitals of Morecambe Bay, created a platform, and we then work with clients, say, right, you need to give us these data items. Can you give us these data items? We put them into the system. And as you can see there, within 3 weeks, the full system was up and running. Then after 3 months, Jenny and team were able to configure and tweak it for those localizations, those local ways of defining metrics or local metrics themselves. But they have the ability to actually configure and change things themselves. But actually getting up and running, 3 weeks, it was done. In very, very simple, and that's one of the key things that we've tried to do, is to make it as simple and possible to actually deploy. You can see there that the Tayside team are able to locally configure. They can go in and they can change which metric appears where, what is the metric, what are the constituent parts. Do we want a bar chart, do we want a line graph? You have complete control over how you actually facilitate the system, what it's showing, without the need for us to come in and do it for you. And Jenny's team have done wonders with it in terms of dealing with COVID and sort of adapting things as their challenges change. They can adapt the system accordingly. It loads every 3 minutes, so this is literally, I mean, you could actually do it more frequently than that, but 3 minutes is pretty real time. So they know that when they're looking at the screens that you saw on the previous slide, what they're looking at is at its oldest 3 minutes old, but obviously probably much less than that. So you actually know it's literally live information. And as Jenny mentioned, it's that bird's eye view across all the acute community and mental health beds. You can see it all on the screens in front of you. You don't need to be logging into a computer, navigating through web pages, going through different screens. They are there on those screens in front of you permanently. And you can actually use your finger. These are touch screens. So the numbers you can see in that sort of diagram or the screenshot at the bottom, you can actually press those with sausage fingers and up pops the sort of granular detail underneath. And you can actually then see the relevant information that you need in order to make the relevant decisions for you. You can filter across multiple hospitals, different wards, if you've got specialty groups, side rooms. All of these are configurable things. Press of a sausage finger, and then it filters everything based on that selection. And you're then filtering and actually making those decisions which are very, very relevant to that decision you have to make. It's absolutely brilliant in that respect. You can see there's a quote from an associate medical director. This is engaging across the health board and trusts as well. You can see, and you'll see those kind of responses from clinicians, senior managers, and so on, of how positive this thing is. Give you a bit of an overview of the different screens. On the slide that Jenny was talking to, you saw that picture of her pointing at the screens. You actually have 4 screens in total, and each screen has a different module sort of on place. You can move them around, but the core sort of platform has 4 screens. And if you try and imagine you're standing in front of those screens as an ED manager or an A&E manager, you're looking at the first screen on the left-hand side, which is the ambulance module here. And this is effectively showing you what ambulances are inbound to your particular hospital where you're working and so on, or trust or board. What ambulances are inbound? What are you expecting? And you can actually press on that and it'll actually tell you more granular information about what's in those ambulances. Are they majors, minors? It gives you a bit of an overview. So you're already thinking ahead, right, I've got some serious things coming in, or the numbers have gone up by 50%. So I know I've got a lot of people coming in. I need to start thinking ahead. You then move to the next screen, which is your A&E module. What have you got sat there waiting? What's in front of you now that you're having to deal with? Number of patients, performance metrics, what's the severity of each of those cases that sat there waiting? Are you about to breach any performance targets that you might have on waiting times within A&E or ED and so on? Do we need to prioritize or reprioritize to obviously do that? And so again, you know what's coming in from an ambulance, you know what's sat there in front of you, so we're already starting to link that information together and start to make ideas and plan and work out what you need to do. The next screen along, so again, imagine now turning slightly to the next screen. This is your inpatients. What's actually going on in the hospital itself? Who's in a bed? Who's, what's the position in that bed? How many people are likely to be discharged at a certain point throughout that day? How many people are maybe, there's a delayed discharge? What's the reason behind that delayed discharge? Is there anything we can do? We know from our ambulance screen that we've got 100 people inbound. We know from the people waiting in A&E that we're almost at capacity. We need to start getting these people out and getting them into beds if they need them. But we've got a blockage in the beds. So I need to be speaking to maybe ward managers and so on to try and help. What can we do to help? Because we need to kind of liaise with each other. So all of this is linking it all together. That last screen on the right-hand side, bed status. What's the overall position across my entire hospital, my entire health board, my entire trust in terms of all of the wards? What's my bed status? How many beds are available? How many beds are taken? How many beds are closed for cleaning, for infection control, and so on? So again, you've now got this complete 360-degree view. I know what's coming in. I know what I'm dealing with. I know who's currently in sort of an inpatient beds and so on, and I know the bed status. So I can now make all the decisions I need to make in order to try and streamline that flow and help the flow move. It's just that honestly really, really important to have that 360-degree view, and it's every 3 minutes at the moment. It's refreshing, so what you're looking at is up to date, real time. You can see there at the bottom, operationally critical, near real time patient flow application. That's what it's designed to do. Now we actually took this a little bit further with Jenny and team, because it's great having that real-time data flow and so on, but actually we then started to implement some machine learning, some AI, some predictions in there. So not only do we know what's actually coming in, what are we expecting, we can actually then start to predict things. So at Tayside now, using some machine learning algorithms, for every patient that's coming into their ED, they get a score. So when they've been triaged and so on, they get a score for every single patient, which tells them what's the likelihood of that patient needing to be admitted to a bed later down the line. And this has been ratified and checked with clinicians. As I said, they've been involved throughout. So it's something that's important that they are happy with that score and they can trust that score. And we're in a very good position with that. In addition, how many and which inpatient admissions are likely to become a delayed discharge at the end of their patient stay? If we can predict who's likely to become a bed, so we know we've got 50 people coming into A&E or ED, of those 25 are likely to need a bed. Right, we now need to plan ahead. How many beds have we got available? Have we got enough? What's the current inpatient position? And so on. As you can, hopefully what you're sort of getting that picture is you'll be able to start making decisions, but actioning those decisions and actually making something happen to improve that flow. The delayed discharges as well. Can we do anything to prevent those from becoming delayed discharges? What do we need to do? What's the criteria? Right, let's do something about it so we can actually remove that as a blocker and again, ease that flow through the system. Honestly, when you stood there looking at these 4 screens, the ability to actually make those decisions is huge. And I think you probably find, Jenny might allude to this later, but in A&E and ED departments, you have huddles throughout the day to try and manage, let's talk through everything we need. And what we find with Command Center is a lot of hospitals have more huddles, but they spend far less time in those huddles because they're not running around trying to get information. They're spending that time using the information on the screens, making decisions, not just collecting data to then try and make a decision. So again, that real-time nature, having access 360-degree view, really, really powerful. Back to you, Jenny. So back to me and sort of looking at some of the other aspects of this. Again, great looking at things that you're expecting to come in and so on. But because we've obviously got sort of historical data, or not lots of it, because the focus on this is here and now, but we are actually able to use that data to then start to show a comparison of sort of current activity compared with what we're expecting it to be. So in these examples, you can see on the bottom left there, you can sort of see that the attendance is, you can see in the last 7 days actual activity, but against the predicted activity. How are we doing? Are we higher this week than we were last week? Is it less than it was last week? It just gives you the ability to kind of think ahead, but also plan your staffing. It gives you that ability to kind of think, you know, okay, where are our peaks and troughs? Are they consistent over time and so on? Well, we can then adapt our staffing accordingly to that. And start to be a little bit more intelligent about how we sort of manage those things. But it really gives you the ability to kind of just think slightly ahead, not way ahead. We're not planning for next year and so on. This is just about us individually, but as the department, you know, are we expecting this to rise in the afternoon, in the morning and so on? How are things kind of changing on a Tuesday, on a Wednesday, on a Friday and so on? And it just gives you that visualization. Jenny mentioned herself about the sort of things going red and so on. You can see in the bottom right-hand corner, there's a couple of metrics there that are red. You know, they're triggers, they're escalations. So with these systems, they have to be simple, and hopefully you can see how simple they are. I learned in my degree, software engineering, keep it simple, stupid. If you make things too complicated, which as an engineer might be really exciting to do, but you've probably lost half of your users. People that are using these systems need to be able to see the information and make a decision incredibly quickly and not have to start worrying about what does that mean? What does it actually do? You need to see big numbers, big bold charts, big colors, and look at something. It needs to hit you in the face and tell you need to act on this, but that's okay. So in this scenario, there's 2 reds. So I know as a person that's my sort of trigger point, right? I need to focus on those 2 areas because they're red. So I know straight away I've got to look at them. So it's giving you those kind of triggers to actually make you realize, I need to go and look at that. So it's almost like a glance. I can have a look, right? I need to focus on something. So again, you know, those predictions, it's giving the triggers and escalation points to help you make the right decisions at the right time, hopefully. There's a bit of a whistle-stop tour, but hopefully that's giving you an idea of what can happen. And collaboration is key. That none of this would have happened without us working with the NHS in the UK. It's not just us forcing the system down their throats. That collaboration is absolutely key, both from us and from an organisation level, but as Jenny alluded to there, internally as well. Really, really important. Collaboration is one of the key words in the success of the command centre. Thanks very much.
Amazing. Thank you so much, Barney and Jenny. And I'm turning it over to Eric next so that we can keep it going. But you've generated so much thought in the chat already, and we're going to come back and do Q&A together with Leah and Louise. So Eric, I'll turn it over to you, and we look forward to talking to everyone again.
Sure, and I'll try and be somewhat, well, not as verbose as I've been known to be. Just for complete transparency, in the introduction and on the website, it noted that I'm with the Public Health Agency of Canada. In fact, I'm actually in between jobs at the moment. My last day, in fact, working on this pan-Canadian health data strategy was actually last week, because I am on my way. I'm jealous of Jenny and Barney being over in Europe, so I'm actually moving to Paris as of the end of the month. So I'll be actually 1 hour on the other side of you guys, but maybe I'll come up to Tayside and see it live. That would be fantastic. So what, but like the work that I've been helping on trying to bring attention to the importance of data and coherence of data in health in Canada, that's been largely my focus for the last couple of years. And I feel like it's definitely getting a significant amount of traction. I would say, aside from the work of the expert group that Elise summarized, that I had the privilege of actually helping the expert group collate their advice and provide that advice faithfully to various provinces and territories, and that was one of the discussion topics at the aforementioned health ministers meeting last week. But hearing and actually seeing manifested this group publishing its patient declaration of health data rights last year, that was just magical to me. Like having patients being loud, saying this is what we expect of our health system in Canada, I think that that is the type of thing that we need to be doing and doing more in Canada perspective, from a Canadian perspective. I hear Alika talking about the importance of data to provide better health in Canada, the challenges of overcoming, I would say, the cultural barriers that are largely in the way in order to affect the type of system change that we need to really drive within Canada. I see the realistic examples that are coming out through the value-based care that Eva talked about, from the examples from the US and from Tayside. And we see these examples of integrated, effective health really emerging at scale in many other countries around the world. Canada, in my perspective, is largely burdened with, have an enormous asset with our intelligence, with our collective resourcefulness, our abilities around emerging tools and technology like artificial intelligence are frankly, I'll say significant. Like we have 2 out of the top 5 AI centers in the world. And yet our ability to scale the innovation that we create in Canada is significantly hampered, because I think in large part we like creating the new, creating the shiny. We get rewarded for the shiny. We don't get rewarded for the mundane. And the mundane is scaling the excellent innovations that we have, leveraging the work of others, finding new ways of delivering care from 100 patients to delivering it to 100,000 patients at that type of scale, and then ultimately up to the 38 million people in Canada. I like what Devorah put in the chat, that stealing with pride. It is the greatest, the greatest comment is being repeated, being replicated, being copied. And so we should be defining success of our health systems, not of delivery of a new fancy system within a new hospital or something like that. We should be defining success as meaningful scaling of the various initiatives that we have, which is not that hard of a step. But when you define success as scale, it means that part of your implementation of your system must be identifying what are those opportunities to scale and designing your solutions to actually achieve that scale that you want in and of itself. And I think that's where I've been reflecting a lot as I've been listening during the afternoon about like, what is it, how can we amplify the voice of the public, of the patient communities across Canada to actually get the decision makers to break their inertia that they have significantly built up over the last 30, 60 years or so. And I think that patients are the secret sauce. I think the patients are the major lever that could actually tell our decision leaders, to tell the elected officials that our expectations, we expect better of you than what you are delivering for us today. We expect that data are that we have the ability to measure the effectiveness of our systems. We heard a lot about that from the value-based care perspective, but also that my data follows me wherever I go. When I move from BC to Ottawa, I want it to be easy to recognize that I had two shots of COVID Moderna here. And so when I get my COVID shot in Ottawa, it's my third, it's not my first. But our systems weren't designed to do that because they weren't designed to talk to each other. And it was actually enormously hard for people to actually do anything across borders in Canada. And yes, there is the aspect of licensure, which absolutely makes sense to me. But from a person perspective, our ability to move within Canada is enormously difficult. You can imagine what my move is going to be like when I move to France. And frankly, I'm going to learn a lot about it. And frankly, I've already had a more positive experience in moving to France than I've had, some people have had with moving within Canada. It is a little bit antithetical to think that it is easier to move to another country and then move back to Canada than it is to actually move within Canada. And that is, I think, a large part of what we've actually created in terms of our systems and our solutions. So I think that and sorry, the last point I wanted to make there was I think of the people who live in Gatineau, who represent some of the 40% of the patient population that goes to the Ottawa hospital that is in Ontario and don't get continuity of care from the health records that are generated in Ottawa to their healthcare providers, their primary care providers who live in Gatineau. And frankly, people have died because of that lack of continuity of care between Ontario and Quebec. I think of the women who are flown from Yellowknife down to Calgary or Edmonton to deliver their children, and the lack of continuity of care from their health records from the Northwest Territories down to Alberta. I think of the lack of continuity of care for people who live in Lloydminster, which if you don't know, the center, the downtown of Lloydminster literally is on the Saskatchewan-Alberta border. The hospitals in Saskatchewan, the primary care doctors in our Alberta. How do you actually manage it back and forth? And so like these are idiosyncratic situations, but realistically, data should follow me. And this goes to Elise's example that I will say a typical, because a typical patient in Canada today is a multi-chronic patient. So a typical multi-chronic patient will have upwards of dozens of interactions through different channels in our health system. And how do they actually have meaningful access to their own records to make sure they understand their own health outcomes and remember it over time? How does their care team provide excellent care for them to actually understand their health history, to provide excellent care over time, to remember that they are actually allergic to this particular drug because they had a bad reaction 20 years ago and their pharmacist remembered and actually is able to prevent a prescription for a new medication because it was something they were allergic to 20 years ago. That happens. and lives are saved because of the memories and the long-standing relationships patients have with their providers. But we shouldn't rely upon those heroic efforts. We should rely on the mundane efforts of ensuring that data are captured in trusted health systems in and of itself. So one of the things that I wanted to call out, and so this is where I was actually going to bring up some polling questions. There was a study that has been recently done by the Health Data Research Network, which is a group that's based out of BC, but connects with all the various research organizations across Canada. And they actually did a poll or did a deliberative analysis with a patient group to say, what are the scenarios under which that you expect your data are shared within the health system? And through a significant analysis, identifying more than 90 different scenarios where data may be shared, they came up with three where there was unanimity amongst that patient group to say, yes, we believe that these are the scenarios wherein data should be shared by default. And so with that, if we could, so I wanted to test with this group to see, well, that group, it was a group of 20 patients, so it was small. We have a fairly small sample size here today, but I would be curious to see to what extent there was resonance with this group. And then it may be an idea for this group to say, how can we amplify these findings, both within our patient communities and with our elected officials and the design teams going forward. So if you want to pull up the poll, there you go. So the first question, so this was centered on social license. So the expectation for the public by default is that it is within social license for health data to be used by my healthcare providers to improve their healthcare decisions for the services provided to me. So just rank that on 1 to 4 to see where you sit. I'll give you guys a couple of minutes. Oh, I think I've got to, I'm probably an attendee, so I've got to submit it myself. And I'll give it another 5 seconds or 10 seconds. Okay, I want to pull it up. Can you pull up the poll? Can you show it? Not sure if it's easy for the guys to close the poll. There you go. Totally agree, some would agree. Not surprisingly. Let's go to the second question. And this just give you a sense of the types of things that this group came up with. And I would think you would agree that at least in that first scenario, we don't do that. Our data are not shared amongst our healthcare providers in order to provide best decisions about me. Second question. It is within social license for health data to be used by governments, facilities, health system administrators. I'll put it writ large. Those who have a fiduciary duty to improve the health system, to actually use that data to improve the health system in and of itself. So again, to what extent do you guys agree? I'll submit my answer. And again, if we want to close that off and we can see, so not quite like everyone agrees, some caveats around it, absolutely understand that there's caveats. And this might be, again, an opportunity for the group to say, we agree as long as that patient declaration of health data rights we had last year is adhered to, for example. I'll come back to your question in a second, Terry. And then bring up the third question, which is within social license for data to be used by university-based researchers. So again, academics that have a fiduciary data to protect, to understand the drivers of disease and well-being, which what isn't said here is in order to be able to understand disease, in order to improve our understanding of how to better treat and provide better health outcomes for individuals. And we'll close that off in a second. So let's see what that one looks like. And again, ooh, disagree, sweet. So that one was not as cut and dry. And that's actually really good because I think that it's around those three things. And I think that's where within these areas, having the discussion, because my statement isn't that these are the truths of the world, drive on. My suggestion is there's an opportunity for us to say, here is something that came out of a study. To what extent is it scalable, and what are the caveats for how and when it should be scalable in and of itself? And to the extent that it's not scalable, if it's not default, then it shouldn't be default. And so, yes, if claimed of personal identifiers, and that would be what, and so absolutely, Sharon, totally agree, totally agree. And so these are all the caveats that come with this work in and of itself. And this is where I think the power of this group can really drive this work to say, these are the findings. We expect that these things are designed in the system along with a set of preventative and detective controls going forward. Too often, the health system itself is designed to have preventative controls, which is to say, don't share data unless. And because the unless is really hard to work out, then it is safest for an organization to never share data. Because frankly, they're not incented to actually go out and find out if all the unlesses are actually true. They're incented to make it easy for themselves, and what's easiest for themselves is to prevent data sharing because they have no risk of privacy breach if they never share data. The challenge that we have is that what we haven't effectively factored into the conversation is what are the risks to the individual, to our communities, to our society as a whole if we don't share data? What are the real harms that are created by not generating the types of insights that actually create the positive outcomes for society? And what are those appropriate controls that must be in place, like removing patient identifiers? And I would dare say, like one of the things I know the group I've been talking to, ensuring that there are very clear and explicit penalties for those people who use data that have been de-identified, that have had the identifiers removed, but then use that data in a way that actually directly negatively impacts an individual or a community. And actually having real dollar fines and having our privacy commissioners actually empowered to actually enforce that work going forward. That's the type of thing that I think we need to be thinking of. But having this model that we currently have, where we are frankly only focused on one side of the equation, which is prevent the privacy breach, and without having the yang of ensure that we're using the data for the public good, I think that that is largely our challenge from a data perspective. And because we don't have that dual lens of protect the data and use it for the good, that is actually the thing that encourages the siloed behaviors that we've observed. And that siloed behaviors that we observe are largely what is preventing our ability to scale things effectively and frankly results in the massive amount of fragmentation that we see across the country. And we see many of our the forces that are encouraging the continued fragmentation of data going forward. The major thing that I observe as I think about all this is that in Europe, as they're thinking about their approach to data going forward, as they're thinking, they have something called the Data Governance Act they are deliberating on now, explicitly in their act. They are saying that data from a health perspective should be as open as possible in order to create public good and benefits for individuals, and as protected as necessary. So they're saying they're setting up the tension between it should be used and it should be protected. In Canada, my reflection has been that data are as protected as possible and as open as necessary. And because data are as protected as possible, the easiest way to keep data as protected as possible is to never share it. And so our culture really drives this culture of data protection without thinking about the good that can come out of the data uses. I think that, I know that was actually one of the parts of the tone of the Patient Declaration of Health Data Rights, to ensure the data are open and protected. I think that there is a big opportunity to be amplifying the message from this community going forward, because I think that in order to create the system as we want going forward, and I love the Margaret Mead quote from earlier on, having voices, your voices at that table, at the tables, and insert yourselves into those tables in order to create the system that we want going forward is frankly the only way that real social change is actually going to happen in Canada. And I think that it is literally people who are on this call and many of the friends and neighbors that you guys have that will have the ability to affect this change going forward.
Thank you so much, Eric. So much great food for thought. I'm going to turn it right over to Chanel. Thanks, Chanel, for joining us and go right ahead.
Chanel, you're muted.
Thank you.
Yeah.
Hi,
You're
my name is Chanel Pathak. I'm from Calgary, and you should be able to see my screen here. I'm going to speak about our data working group. I volunteer as the chair of the data working group, which was formed in 2009 at the 2019 Patient Redefining the Future of Healthcare Summit. And the working group is comprised of a small group of volunteers from diverse patient organizations and citizen groups. And all of us have lived experiences as a patient, caregiver, or engaged citizen. Professionally, I'm the co-founder and CEO of Example Health, a social enterprise. And we envision a future where individuals own and control all their health data. And we have a connected health platform, which we want to be the digital backbone of a connected ecosystem. And our first step is creating an electronic data capture platform for researchers to gather participant health data. And people can use their own data to track, analyze, and share with anybody they want in the world. Personally, I was a caregiver to my late wife who passed away of lung cancer. And that is when I was introduced to the information chaos that often we experience as patients and caregivers. And we started collecting her data to find patterns and sharing with the global health team to make better decisions. So we knew the power of health data in our hands. And what I learned from our journey together, combined with my professional experience as a computer engineer, is what inspired me to be a patient advocate in this space. The working group determined that the Supreme Court of Canada has affirmed that individuals, in essence, own their personal health data, while custodians possess the data, be it in paper or digital. And we feel that we all have an ongoing interest in the control over our health data. And through a collaborative effort, the group has identified 11 rights. And a couple of years ago, we developed the Declaration of Personal Health Data Rights, which you can see here. And we'll show you links to the document at the end of the presentation. These are the 11 areas of our 11 rights. And we looked at the balance of the individual right to their own health data, but also sharing the data for the greater good to make better decisions for the public. At its launch in June 2021, we've received support and endorsement by 26 different patient organizations from across Canada. The declaration is non-binding, and we look at this as validation and that we're on the right track, and that there's interest from patient organizations and individuals. Our timing in 2019 was sadly good. As we know, in 2020, we faced a global pandemic, and the federal and provincial and territorial governments across Canada were faced with the major data challenges that were urgently magnified with the arrival of COVID-19. And this urgency of the situation launched the expert advisory group supported by the Public Health Agency of Canada. And also it articulated the Pan-Canadian Health Data Strategy, including a proposed Canadian Health Data Charter. And I want to say thank you to Elise and Eric for sharing more about the incredible important initiative that was initiated, and also really involve the public in shaping the strategy. It's incredible to see the consensus that is forming across sectors and also across the country in respect to health data. Recently, all the federal, provincial, and territorial privacy commissioners met and released a joint statement also showing consensus with our declaration, this charter, and also the Pan-Canadian Health Data Strategy as a whole. And consensus is growing among key sectors and decision makers across Canada, and that we finally need to take a coordinated step together in a data strategy. And our efforts together must be sustained until the work is done across Canada, across all Canadian jurisdictions. And we feel that none of us can be left behind in the data dark ages of paper records, missed voicemails, and the infamous fax machines. So what can you do to contribute to the urgent changes needed to unleash the power of health data and information in Canada? First, we asked an endorsement of the Declaration of Personal Health Data Rights as an individual or an organization. You can socialize the Canadian Health Data Charter and the Pan-Canadian Health Data Strategy amongst your members and key stakeholders. And finally, we always look for people to join our data working group. There'll be more announcements and opportunities related to advancing personal health data for the benefit of everyone across Canada. But in essence, this is accumulation of 2 years or 3 years of work amongst a small team, but we are gaining tremendous momentum as foreseen by the 26 patient organizations have endorsed it, and also now visibility with the different governments at the different levels across Canada. Thank you.
Amazing. Thank you so much, Shanil, for walking us through that. And I think, Leah, you included the link to the declaration in the chat. So I'm going to turn it over to you, Leah, to wrap us up. And thank you to everyone. And Leah, go right ahead and get us going.
There has been so much active discussion and ongoing questions in the chat. And I also just want to acknowledge that we are running a bit over time, but this is such a vital conversation that I think it's worth borrowing a little bit from our breakout sessions for it. And I think some of the questions might be amongst yourselves. So I encourage you to, by all means, unmute and ask. There were some good questions going into the chat. Elise, I think you had one. A couple for our Scottish colleagues, for example, one about were patients part of the design process or are the part of the ongoing improvement process with the command center in Tayside. I think that was one of them. And also just the applicability of the system to across settings and across geography. Did I get that right, Elise?
I'll do my best to answer that. So Jenny's had to leave, unfortunately. It's 10 to 9 in the UK, and she's got sort of 2 young girls who need to go to bed. So she sends her apologies. So yes, so you've just got me. Apologies on that as well.
No.
So were patients involved? Directly, no, but indirectly, yes. And I know that's the bit of an ambiguous answer, mainly because the system that we created was designed around the pressures, the needs of the individual hospitals and trusts and health boards. And it's very much on a case-by-case basis rather than one size fits all. And obviously each hospital is managing their own patients, getting their own patient feedback and so on about what's good, what's bad, what's working, what's not working, and so on. So that information from patients is fed back, and it's something in the UK we do every single year, patient surveys and so on, which is fed back into those systems, which are then collated by the health boards. And again, it's something else that we support them with in terms of that collation of data and analytics of that data. That's then informing the decisions around ED and around the needs of the systems. And obviously that then informs what they need in terms of those solutions to help them manage. So that's what I was trying to sort of say when yes and no. So our system is based around the requirements of the individual hospitals and trusts and so on. And their decisions internally will be based on the pressures, demands, the capacity issues and so on, which, all comprise of that patient data and information as well. We didn't directly speak to patients though. So whether there are plans to do that, I'm not sure, but they certainly do. Hospitals do ask patients directly how their experience is. It's like going to an airport, you get little smiley, unhappy faces and so on. It's that kind of concept, and we are actually applying that in hospitals in ED. Not so much in inpatient spells, it's slightly different, but certainly when it's you're going in and going out and so on, what was your experience like? And the second question was, how can it span sort of regional and so on? I mean, the platform we use couldn't care less the scale of what you're talking about. the key thing is the data. And does that data, is it the same sort of, are you talking the same language? You can't compare apples and pears, for example. You need to make sure that that data is consistent across those entities. Not to say we can't tweak things slightly, but you want to have the ability to. So we've got a concept in the UK of integrated care systems, which is groups of healthcare entities that all work together. So hospitals, social care, councils, police, ambulance, fire, mental health trusts, community services, they all work together under one umbrella. And so we've now got these entities where we need to implement command centers at that level, which then feed down into all those entities so that you can see at that level, albeit aggregated, because you don't want identifiable at that level. And then when you get down to the constituent parts, acute trust, community, and so on, you can then drill into the relevant data. It's all fully governed, so it knows who you are, what access you should have, what decisions you need to make, and then gives you the right information. But in terms of the capability, yeah, it can literally tick any box that anybody needs. It's just all based on the requirement.
Thank you.
I want to thank you so much, Barney. I want to ask a blunt question, and I wonder who would be interested in taking it on. But we all know how much work went into preparing the Pan-Canadian Health Data Strategy, how much work went, engagement with various levels of government and in the process and doing that. Saw the huge opportunity, obviously, represented by the Canada, that bold move that obviously was well coordinated and planned, and I'm sure like lots of background work in terms of the federal health minister saying, hey, we can have increased Canada health transfers if we can agree on a national health data system, I think was the term used. But hold on, guys, I think my earbuds are dying. And we know that the response, I mean, and I'm going to be blunt in terms of my feeling when I read some of the, the media responses from the provincial and territorial side, which apparently came through the premiers at the last minute, I don't know, which was, the way it reads is kind of like, well, no, this is the provinces and the territories, this is our responsibility, this is our data. And all I could think is, no, just give us the money without conditions, nothing, no conditions. And so, I felt like, okay, well, I'm not a citizen of Ontario. This has already been talked about extensively here, right? I'm a citizen of Canada, and this is an unacceptable response. And I want to flag for those who are still here, because we were able to work on the declaration, we know who've endorsed it, and we've been engaging in media work and writing to the FPT commissioners, et cetera, privacy commissioners when they said good things. When we saw that happen, Louise and a few others were able to quickly scramble and say, okay, we need to write as patient groups and say, hey, to premiers, federal, provincial, territorial health ministers, and the prime minister. No, we said it nicely, but we need a pan-Canadian health data strategy. We recognize the provinces and territories at different places and have discrete needs, but there's common vision and set of foundational pillars that we need to have together.
So Leah, can I just a nuance to this, because I don't want to completely throw the provinces under buses. I think everybody's got, good, bad, and indifferent here, and everybody can take a little of the credit and a little of the blame. I mean, the one thing the provinces did say that resonated for me is that we need to look at each province and where it's at, kind of meet them where they're at to help them move ahead in whatever way they need, given where their starting point is. And I get that. The provinces, we all know the provinces have very different resources and priorities and all kinds of things. The one thing, though, is that that's all fine as long as they're heading to a common vision at the end. So that's the key, is that, we know where we want to be. We may all be in a different place at this moment in terms of getting there, and that's fair enough, but we all have to be aligned in terms of where we're headed. Otherwise, we're just going to be in the same mess really that we're in now. And to your point, Leah, I mean, we are a federation, but the federal government has a strong legal and policy implication for health, including the Canada Health Act. And that really, in my view, means that the provinces have to absolutely create some alignment. All those priorities under the Canada Health Act talk about alignment and the ability for people to move around and for things to be sustainable. So it's not one province gets to decide that alone. The Canada Health Act says we decide those things together.
So,
and so the question I want to ask from all of our wise people on this panel are, any advice to us as we continue to move forward in the context of this, of this back and forth between provincial and territorial and federal political decision makers?
So not surprisingly, I'll lean in first.
Please do.
I will say the work I did with the expert group and the published reports where Elise was involved, that was advice on a pan-Canadian health data strategy. There are efforts with provinces and territories to write the actual pan-Canadian health data strategy. And one of the facets that would easily come out from that work is identifying that it would be a co-developed product, and it being co-developed would recognize that provinces and territories are vastly different places. And so the pace at which a pan-Canadian approach can be implemented is going to be vastly different across the country. One of the things it's absolutely would identify is that there is in the same way we have bad challenges with capacity within healthcare workforces, with providers and nurses and other health professions, we also have capacity problems in our data workforces across the country in and of itself. And so I think that's an area where identifying that we not only have to ensure that we have the health professionals from a health workforce strategy that is suitable for serving the needs of Canadians, but also to have a modernized workforce that actually can leverage the modern techniques and tools, et cetera, that we have in Canada. And a health workforce strategy should actually address should not just address how we can actually do more of the same in the health system, but how we can evolve the health system to be the better digitized health system of the future in and of itself. It's cool. And there is the other thing I was going to say was, from a patient perspective, I think that oh crap, I forgot what I was saying. Somebody else say something smart and then I'll remember.
It's okay. I think baking it into the HHR work is a smart thing already. So thank you for that. Any further thoughts? Any last questions or comments before we move to breakout?
I really just wanted to have the opportunity to thank all of the panelists and all of the people who've done so much work, Chanel, and our gang on our declaration, and of course Eric and Elise and all the expert advisory group work. And I bet my colleagues in Scotland who met me at a international value-based conference didn't realize that once you get in with me, you never get out. That's just how it is. So
and that's just how we like it.
Oh, good. Well, I'm glad to hear. I'm glad to hear, because that's just how it is. So I guess we picked the right topic at the right times, and that what we always talk about, the right topic at the right time for the right people. Well, I think we are right on top of this one. So thank you all so much. And I guess we're off to breakout rooms now, Leah.
Yes. And I just want to reiterate what Louise said. Incredible work, all of you, and incredible working with you. And I know we're going to continue to collaborate and continue to seed and move and change shift mindsets so that we can get the health data systems that we need, interoperable, person-centered data architecture that we need and deserve in this country. Thank you, everyone. Axon, please feel free to move us into breakouts. I look forward to hearing from all of you who have made it through all of this fantastic content today. See you soon on the other side.